I'm really excited to teach you about general internal medicine. I think that it's a broad topic. These are all of the different things that we're going to cover today. And I know they seem kind of random and pulled together, but the thing to remember is that each of these little pieces, when all added up, take up about a fifth to a quarter of the internal medicine recertification exam. So it's worth paying attention to. So we'll start with the drug interactions and important side effects. So, as we know, warfarin is one of the most dangerous medicines we give, right? So anticoagulants, opiates, and hypoglycemics. And there's two mechanisms that other drugs can use to interact with the warfarin. The first one is altered intestinal flora. So remember that vitamin K synthesis starts in the intestines and then moves to the liver. And so if you decrease the amount of intestinal flora, you're not going to have enough substrate to make the vitamin K. So you can see that many antibiotics, in fact, almost all antibiotics, will change the intestinal flora and lead to elevated INR. It can also happen through the CYP enzymes, right, in the liver. And I think these CYP enzymes are one of the things that I always found very intimidating, but they come up all the time, right? And so I think it can be simplified quite a bit if you just think about there's inhibitors, inducers, and substrates. So the inhibitors are really three types of things: psychiatric meds, antimicrobials, and cardiac meds. And almost all of them will fall under that inhibitor column. On the other side is inducers, and this is where almost all of your anti-epileptics are. And so I think it's important to sort of keep those separate, and we'll talk about, there's always exceptions to every rule, but if you can remember that there's these three things: antimicrobials, cardiac meds, and psychiatric meds that fall in inhibitors, and then the anti-epileptics are all in the inducer side. It'll help you a lot. So to that point, here we have a bunch of inhibitors, right? The azole antifungals, amiodarone, a cardiac med, gemfibrozil, a cardiac med, SSRI, a psychiatric med, atorvastatin and simvastatin, cardiac medicines, right? And so since all of them are inhibitors, we don't metabolize our warfarin as well, and our INR goes up. The other thing that's important to remember, especially in the days of the opioid epidemic where we're expected to use multimodal pain control for all of our patients, is that acetaminophen also has an important interaction with warfarin. If you take more than 9,000 milligrams a week, which is 325 milligrams every 6 hours, it increases your risk of an elevated INR by 10 times, right? And so when we're supposed to be putting most of our patients on a gram of acetaminophen every three times a day, a lot of our patients come very close to this risk. Hyperkalemia is another important side effect of many medicines. There are basically two mechanisms that can cause this to happen. The first one is decreased production of aldosterone. Remember, aldosterone works in the distal kidney to cause excretion of potassium and intake of sodium. So both ACEs and ARBs and NSAIDs can decrease the amount of aldosterone in your system. The other mechanism is aldosterone resistance. So if the aldosterone gets to the distal kidney but it can't work, then that's also going to inhibit that same exchange of sodium and potassium. So these are potassium-sparing diuretics and trimethoprim sulfamethoxazole. This is an important side effect of TMP-SMX, especially in the population of the elderly patients and HIV patients. So, HIV patients a lot of times come into the hospital, they get diagnosed with PJP pneumonia, and they get high-dose TMP-SMX. In that context, many of them will develop dangerous hyperkalemia. And here you have, once again, the mechanism that it actually blocks the channels so you can't excrete the potassium and take in the sodium. So thyroid disease, I don't know what you guys do. I'm a primary care doctor, and so my patients constantly have problems with their thyroid hormone. I just saw someone this week, and I asked him how his medicines were going, and he said they're fine. And then I checked his TSH, and it was 99. And so then when I called him, I found out that he was actually taking his levothyroxine with all of his medicines in the morning with breakfast. And as you can see here, the dosing can make a huge difference because all of these medicines, he was on a proton pump inhibitor, and all of these things can really decrease your ability to absorb the levothyroxine. It's also really important to think about other malabsorptive diseases and celiac diseases here just as an example, but you should think through all of those things. So they really need to take their levothyroxine first thing in the morning, an hour before breakfast, and an hour before any of their other medicines. The other mechanism, just like we were talking about before, is T4 catabolism. And what do you think catabolizes T4? the CYP enzymes, right? Our favorite things. And so here we see 3 drugs, phenytoin, carbamazepine, and rifampin. And it all makes sense, right? Because phenytoin and carbamazepine are anti-epileptic, so we know that they're inducers. But here's rifampin. So this is the first exception to the rule. So rifampin is an antimicrobial that instead of being an inhibitor, it is the one antimicrobial that is over on the inducer side, right? So increased catabolism of T4 causes the levels to go low, and so even though I'm giving this guy 200 micrograms of levothyroxine, he still has a TSH of 99. Bisphosphonates, another very common medicine in my practice, and we lots of times think about the common side effects of bisphosphonates, especially the esophagitis, right, and the horrible pill esophagitis. This is why these patients, this is another medicine that we take with a full glass of water, only this one is, on an empty stomach on some random Saturday, and we sit up for an hour afterwards, right, to make sure we flush it through. But musculoskeletal pain is another common side effect of bisphosphonates. So it happens in 4 to 5% of these patients, and it's much more common than these dread complications like osteonecrosis of the jaw or femoral fractures. So it's important to remember it in the differential along with statin myopathy and polymyalgia rheumatica, and especially in these elderly patients who get on more and more medicines and then come in with aches and pains and you can't figure out which medicine you need to stop for them. QT interval prolongation. So this is sort of related once again to the hyperkalemia. We've been finding out that more and more of our medicines cause increased risk of cardiac death through this mechanism. So here we have the antiarrhythmics, which I think we would all remember, macrolides and fluoroquinolones. So this is why they've really been going out of favor lately, and we've been decreasing the amount that we prescribe things like levofloxacin that used to be very common in our practice. The TCAs and citalopram along with other SSRIs, so a lot of the psychiatric meds. Methadone, which is important to know about it, once again, because of the opiate epidemic and because methadone causes these strange biphasic T waves, and you actually have to measure the Q interval all the way to the end of the lower part of the biphasic T wave. And so it's very, very important to monitor their QT in patients on methadone to prevent opiate withdrawal. And then ondansetron and some other GI medicines, right? Things like metoclopramide can also cause QT interval prolongation. And so we can have a patient who's doing fine on all their medicines, goes into the emergency room, gets prescribed one of these medicines, and then comes back to us in clinic with prolonged QT. So statins, we've talked about them a lot. It's important to remember that similar to the bisphosphonates, these dread complications are quite rare, thank goodness. So the myalgias are very common, 5 to 18%. I don't know about you guys, but it feels like in my practice this is like 80% of my patients say they have statin myopathy. Thank goodness there's many of them that I can try. The abnormal LFTs also are quite common. But we actually don't need to monitor for them anymore. And remember that we'll tolerate abnormal LFTs up to 3 times the upper limit of normal before we're going to stop the statins, right? Statins are one of our best medicines to prevent cardiac disease, whether it's in primary or secondary prevention. And so we'll sort of tolerate borderline elevations in these patients, given that the risk of liver failure is so low. So interactions with statins, now we're going to talk about our favorite enzymes again, right? So the CYP enzymes. And so here we have a group of medicines here, amiodarone, cardiac med, clarithromycin, antimicrobial, azole, antifungals, antimicrobial, and then here's another new one, grapefruit juice, which we all remember about grapefruit juice. It's on the inhibitor side, right? And so when you inhibit the metabolism of the statin, then the statin level increases and you put yourself at increased risk for these various complications. The other thing to remember is that one of the cardiac medicines on the inhibitor side, even though we use it all the time and it's pretty benign otherwise, is amlodipine, right? And so the interaction between amlodipine and simvastatin seems to be pretty specific to those types of medicines and can show up very easily in practice just because they're both so commonly used. And then, just because you might be sick of the CYP enzymes, we have phase 2 metabolism with glucuronidation, and this is where the fibrates can really make a difference and can cause worsening levels of the statins, which I think we probably all have seen that in practice also. Hyponatremia. So this is actually very near and dear to my heart right now. I had one of my very favorite patients. She's 93, and she came in to see me. She was falling, and she was like, I don't know what's going on. And I checked her sodium, and it was 126. And I found out when I was at a conference, and I freaked out, as you guys can imagine, and called her and sent her into the ER. And she was one of these people who is taking SSRIs for a long time, hydrochlorothiazide for a long time, and something just happened that sort of flipped a switch for her. And then once we stopped the hydrochlorothiazide, she's back to normal. The other one to remember is carbamazepine. You start to notice these bad actors that just keep showing up, right? Carbamazepine seems to be on a lot of these lists. So if you look at the risk factors for hyponatremia, my poor patient has almost all of them, right? So she's way older than 65, a woman. She's on diuretics at the same time, and she's a super thin lady. I mean, her BMI is, I think, 20. And it does look like SIADH on testing. So when she showed up in the emergency room, the sodium was high, the urine osms were high, the urine sodium, sorry. Her serum sodium was obviously low. And so it looks a lot like SIADH on testing. So, uric acid. So this is another thing we see quite frequently. Uric acid levels are correlated both with cardiac disease and with gout flares. And these medicines, diuretics, can decrease the secretion of uric acid. Niacin and cyclosporin also act in the kidney. So this mechanism is different than the one we've been talking about otherwise. Instead of the CYP enzymes in the liver, we're talking about excretion in the kidneys. So now we are going to do some audience response questions. The first one, this is a 69-year-old woman who presents with symptoms of severe muscle pain and joint pain. It's been present for the past 3 weeks. She has had no fevers, chills, or trauma. She has a past history of hypertension, hypothyroidism, coronary artery disease, osteoporosis, GERD, and depression. Her meds are as listed. What is the most likely cause of her pain? Yay, good job, guys. So alendronate, as we discussed, is a common cause of musculoskeletal pain. I always like with these questions to think about what I would have looked for if alendronate wasn't there, right? So the first thing I look for when I see that the question is about pain is the amlodipine-simvastatin interaction, right? And then you can look for any statin along with one of those CYP inhibitors, right? The cardiac meds, the antimicrobials, or the psychiatric meds. And then what if none of that stuff was there? She didn't have any meds at all, or she was just, or she wasn't on any of these things. I think you could think about hypothyroidism and think about whether she's taking her levothyroxine properly, right? Because if you're very, very hypothyroid, you can get some myalgias. And then finally, the polymyalgia rheumatica, if she has central muscle weakness. Okay, you get called with a panic lab of an INR of 5.8 for a 52-year-old woman with a history of hypertension, diabetes, and atrial fibrillation. When you review her records, her INR has been stable between 2.0 and 3.0 for the past 8 months. She is finishing a 7-day course of an antibiotic prescribed by an ER physician for bronchitis. She does not remember the name. Her medicines are warfarin, metformin, hydrochlorothiazide. So what antibiotic do you think she was on? Good, so we're split between azithromycin and trimethoprim sulfamethoxazole. I think those are definitely the choices we're gonna go down to, right? Remember that the beta-lactam antibiotics are generally very benign from a side effect perspective. They don't cause problems with the CYP enzymes the way the other ones do. And so you're between azithromycin and TMP-SMX. I think the clue here that the TMP-SMX is correct is based on the course of the antibiotic. Most people use 5 days of azithromycin, whereas the TMP-SMX would be more typically used for a 7-day course. All right, this is a 38-year-old woman who you're seeing in clinic with a prosthetic mitral valve. Her main complaint is bruising with minimal trauma, if any. Her INR 6 weeks ago was 2.9, and today it's 6.9. Which of the following, when taken on a daily basis, could explain her increased INR? Perfect. Good job, guys. So acetaminophen, like I mentioned so many times, right, can definitely increase the INR. And number 4, a 60-year-old man comes in complaining of aching in his shoulders and thighs. He's taking benazepril, amlodipine, warfarin, omeprazole, simvastatin, and loratadine. Which of these drugs is most likely contributing to his symptoms? Good job, guys. Amlodipine and simvastatin, right? We're never going to forget it. A 67-year-old woman presents with 1-week complaints of headache, nausea, and fatigue. Her daughter also tells you she appears confused at times. She has GERD, bipolar disorder, hypertension, and osteoporosis, and her meds are omeprazole, lithium, fluoxetine, alendronate, and amlodipine. Her physical exam is normal, and her labs are notable for a sodium of 121, a potassium of 3.9, BUN 4, creatinine 0.6, urine osms 379. Which medicine most likely explains the hyponatremia? Good, fluoxetine. I think that it is interesting to think about what we would worry about in this case if there was no fluoxetine, right? And I think that you would have to look for diuretics. You would look for other endocrine problems such as adrenal insufficiency, right? If their potassium was high, then you might think about that. I think that this lithium, 15% of you chose lithium, and I think that makes sense because we lots of times think about lithium as a bad actor. But remember that a patient just like this could present with lithium overdose, but then she would have a high calcium, right? So lithium acts to change the sensitivity of the PTH receptor so that the PTH levels go way up and the person becomes hypercalcemic, and they can present just like the hyponatremic patients with falls and confusion and delirium. An 85-year-old man is brought to the ER for evaluation of weakness and nausea. He was diagnosed 10 days ago with prostatitis. His other problems include hypertension, heart failure, and chronic renal insufficiency. He's on carvedilol, furosemide, TMP-SMX, digoxin, and atorvastatin. His blood pressure is 100/60, heart rate 100, temperature 98.4. On cardiac exam, he has a grade 2 out of 6 systolic ejection murmur and lower extremity edema. His sodium is 132, potassium 6.8, BUN 37, and creatinine 1.6. What is the most likely cause of his hyperkalemia? Good, 92% TMP-SMX, right? Commonly cause hyperkalemia, especially in the elderly and patients with HIV. I think this is the last one. A 73-year-old man with type 2 diabetes, coronary artery disease, hypertension, and heart failure presents with worsening symptoms of his heart failure. He has had increased PND and orthopnea, and he has had a 15-pound weight gain in the past month. On exam, he has bilateral RALs and 2+ pitting edema to the mid-calf. On labs, his hemoglobin is 32%. It was 37 a month ago. His BUN is 20, and his creatinine is 1.1. His medications are metformin, lisinopril, pioglitazone, carvedilol, and spironolactone. So what's the most likely cause of his increased heart failure symptoms? Good, so the pioglitazone. So this isn't something that I mentioned explicitly, but these are a common cause of worsening heart failure symptoms. For metformin, it's pretty benign, except for the GI side effects, and then this theoretical concern of lactic acidosis, which is actually shown to not be very common or very big of a problem, even in people with renal insufficiency. And then remember, lisinopril and spironolactone were both on the hyperkalemia list that we saw earlier. All right, so now we're going to move to a very related topic, geriatrics, okay? Geriatrics is related, well, there's tons of topics in geriatrics, and we're going to cover them all. The reason it's related is because in geriatrics, if you can stop a medication, do it, right? So medications are almost always causing, or commonly cause side effects in elderly patients, especially because they're already on so many medicines. So if you have an elderly patient and you have a bunch of meds and you have a choice to stop one of those meds, then you should always do it. And the second rule of geriatrics is that if you can't stop a med, then order physical therapy, okay? And I know it sounds like a joke, but it's actually true. It's unbelievable how much physical therapy I order in a day in my normal practice. So, osteoporosis. So the first thing to know that's an update in osteoporosis, we used to put all young women on calcium and vitamin D, but it's become more controversial because of this risk of cardiovascular disease. So at this point, the USPSTF actually recommends against the calcium and vitamin D supplementation unless the person is very high risk for osteoporosis because of decreased weight-bearing activity. However, the National Osteoporosis Foundation does continue to recommend supplementation. The way most of us walk this line is by counseling about dietary calcium and vitamin D intake, because it seems like dietary calcium doesn't hold the same cardiac risks as the supplements do. Here, though, we have talking about elderly patients. The calcium and vitamin D does seem to reduce hip fracture risk, and there's been further studies that really show that it's the vitamin D supplementation, almost regardless of the vitamin D level of the patient, that decreases the risk of falls. So we often now are giving vitamin D to elderly patients just to decrease this fall risk, especially since it doesn't have the side effects of cardiac dysfunction that the calcium does. So what are the risk factors for osteoporosis? These are a lot of the common ones we've known for a long time. Age over 65, a first-degree relative with a fragility fracture, low BMI and weight, current smoker, alcohol drink intake of more than 2 drinks a day, early menopause, because remember that the most quick, rapid bone loss happens immediately after menopause as the estrogen goes away, and it increases the amount of osteoclast activity to decrease the bone density. Currently or previously treated with more than 3 months of steroid therapy at a dose of more than 5 milligrams per day of prednisone. So this is not a lot of steroids, right? A lot of our patients are going to get very close to this boundary. Never mind the patients who have rheumatoid arthritis or some of these other chronic inflammatory diseases. So it's important to remember this threshold because it's actually quite low. And then finally, malabsorption. So this is the celiac disease and a lot of the other things we were talking about before. So who should get a DEXA scan? We used to do it for everyone who was going through menopause, but now it should really be women starting at 65 years of age. And we should do women who are less than 65, even if they're postmenopausal, only based on additional risk factors, which we'll go through in more detail. It recommends screening. So the National Osteoporosis Foundation does say we should screen men over 60 or over 50 with risk factors, but the USPSTF doesn't currently have any guidelines about when we screen men for osteoporosis. The postmenopausal women and men over 50 who have a fracture, I think if you have a fracture, everyone agrees that we should see what your bone density is. So the medicines in osteoporosis. So we already talked about glucocorticoids. It's important to remember that these anticonvulsants, the bad actors, right, the CYP inducers, also show up on this list. Drugs associated with hypogonadism, right? So anything that's going to decrease the estrogen levels is going to cause a problem for osteoporosis and bone health. Thyroid over replacement, right? So patients who are taking too much of their levothyroxine or who are taking these sort of extraneous supplements of thyroid hormone, perhaps through supplements, are all at risk of osteoporosis, cyclosporin, and lithium. So when do we screen for osteoporosis? So the first thing to think about is the GI diseases. So like I mentioned, celiac disease, but also gastric bypass and gastrectomy. More and more of our patients are having these procedures as young people because of the obesity epidemic, and as they get older, most of them are going to need to be screened for osteoporosis as they go through menopause. Endocrine diseases. So remember that these all play in together. So we always know that primary hyperparathyroidism needs to be screened for osteoporosis, but you've also got to remember Cushing syndrome, hypogonadism, and as I mentioned before, hyperthyroidism. Renal insufficiency, so a common cause of secondary hyperparathyroidism, can cause decreased bone loss. Anyone who can't get up and stress their bones are going to weaken over time, so prolonged bed rest is a risk factor. Rheumatoid arthritis and SLE are independent risk factors even outside of the steroid supplementation issue. And then anorexia nervosa, right, which is something related to diet that's separate from gastrointestinal diseases. So then the T-score, something we use all the time, but it's very easy to forget exactly what it means. So it's the number of standard deviations that the bone density of the patient is above or below young normal, right? So that means that when you define osteoporosis with a BMD of 2.5 standard deviations below the mean of a healthy person, then 30% of postmenopausal women are going to have osteoporosis, right? This is different from the Z-score, right? So remember, the Z-score is comparing them against the same, right? So this is comparing you against people of your same age. And in that situation, if you're 2.5 standard deviations below, it suggests that you really need to look for a secondary cause. All right, so the definition. So a normal bone density is a T-score below or above 1.0 standard deviations of normal. For osteopenia, it's -1 to -2.5, and osteoporosis is anything less than 2.5. So, remember it's a negative score, so it's kind of confusing. For severe osteoporosis, this is really when you start having fractures in the context of osteoporosis, whether your T-score is less than 2.5 or not. And the reason that we use these comparing against young normals to define osteoporosis is because it has to do with fracture risk, right? And so since young women are the ones who don't fracture, we want to figure out which of the elderly patients are at risk. So therapy. So everyone should be getting these lifestyle interventions, right? Especially weight-bearing exercises and fall risk prevention. We already discussed sort of this calcium, vitamin D, whether they should come from the diet or supplements. These are the targets in patients who have actual osteoporosis. They really need to try to even log their calcium to see how much they're taking. And it's not just milk, it's also leafy green vegetables, spinach, broccoli, things like that. And then we already talked about the low-dose supplements. So drug therapy. So the first indication for drug therapy is any sort of fracture in your past. The second one is if your T-score is more than -2.5 or less than -2.5, so -3, -2.7. If you have osteopenia and your T-score is between -1 and -2.5, then we're going to treat you either if you have secondary causes, right, which we saw in that list, or if you have a 10-year probability of hip fracture over 3%, or a probability of major fracture more than 20% based on FRAX. So the FRAX calculator is freely available online. I use it almost every clinic day, and it's a great way to predict who's at the highest risk for fractures. It takes into account whether they have first-degree relatives, their alcohol intake, along with their T-score, and will tell you how high risk that person is to have a fracture over 10 years. So what therapy are we going to give them? So the first treatment is bisphosphonates. They are incorporated into the bone matrix and decrease the ability of osteoclasts to degrade it. The duration of treatment is slightly unclear. It seems like we should do it for at least 5 years, but after that, the side effects start to go up, and the bones have really taken up most of it that they need. The one time that you really won't stop it after 5 years is if the person is fracturing while on a bisphosphonate, right? And then it's a little more unclear if their T-score is worsening on the bisphosphonate, and that's when we would start moving down further into this list. So calcitonin is not as effective as these other ones. We use it mostly just for acute pain if there's an osteoporotic compression fracture in the spine. Teriparatide, which is subcutaneous PTH, is useful for people who can't tolerate bisphosphonates, but really the most effective of these secondary choices is the denosumab, which is an injectable anti-rank ligand therapy, right? So it basically turns off the osteoclasts. It's very, very expensive because it's an antibody treatment, but we do use it for these patients who aren't responding or who are fractured, who really can't tolerate them, or because of something like osteonecrosis of the jaw. And then always you have the options of these hormonal treatments, although we don't reach for these quite as quickly anymore because of the cardiac side effects. So now we'll do some more audience response questions. So a 56-year-old woman, postmenopausal, presents with concern for osteoporosis because her 50-year-old sister-in-law just fractured her hip. The patient has never been on hormone replacement therapy. She is an obese, non-smoking woman without any underlying medical problems, and she has no perimenopausal symptoms. She has no family history of osteoporosis. What would you recommend for her? Good. Encourage weight-bearing exercise. I think that you guys are right that this DEXA scan is the main detractor. And I think if she was over 65, or if we found a bunch of risk factors, then we would be very quick to reach for that. But in the context of no risk factors, it's her sister-in-law, so it's not a relative, right? If it was her mom or her sister, then I think that you guys would be right to choose the DEXA scan. Next question, a 65-year-old woman has a screening DEXA scan. She has no family history of osteoporosis. She drinks alcohol occasionally and does not smoke. Her past medical history is negative except for a DVT while on oral contraceptives. She's on hydrochlorothiazide, omeprazole, calcium with vitamin D, and her blood pressure is 140/86. Her weight is 177 pounds. Her DEXA scan shows a T-score of negative 2.7 at the hip and negative 1.8 at the vertebra. What would you recommend? Good, exactly. So she needs alendronate based on the fact that her T-score is negative 2.7 at the hip, right? So since she has osteoporosis, she automatically gets treated with bisphosphonates. And then risk factors for falls is for everyone, right? A 72-year-old woman presents for primary care. She is healthy with the only diagnosis in her record being osteoporosis. She had a DEXA scan 6 years ago with a T-score of negative 1.8 at the hip and negative 1.6 at the spine, with a FRAX 10-year risk of hip fracture of 3.5%. She was started on alendronate. Last year, she had a DEXA scan showing a T-score of negative 1.9 at the hip and negative 1.7 at the spine. What would you recommend? Okay, so a bunch of different answers here. So I think that happened 6 years ago, right? So 6 years ago, she had osteopenia. She had the FRAX score calculation that showed that her risk of hip fracture is over 3%. So she was rightly started on alendronate. The other way that we would have decided that is if her risk of major osteoporotic fracture was over 20. And then 6 years or 5 years later, she has another DEXA scan that shows continued osteopenia. But in the meantime, she hasn't had another fracture, right? Nothing bad has happened to her. And so in this context, we would stop alendronate after 5 years. I think if she had a fracture, we would continue alendronate or continue switching to denosumab. A 63-year-old woman with a family history of osteoporosis presents with a vertebral fracture. She has a workup that reveals no complicating causes other than osteoporosis. Other history includes type 2 diabetes, prior DVT, and severe reflux esophagitis with a stricture in the past. Her exam is unremarkable except for spinal tenderness over T7. So what are you going to recommend? Okay, so it's tricky, right? Because we're trying to figure out what to do in the context of this esophageal stricture, right? Which is obviously a big problem and makes it very difficult of water. That's why we can give her zoledronic acid. It's a IV medicine that's given only, and that's why D is the best answer. So kyphoplasty is very controversial as far as whether it even helps with the pain. So that's not the best answer. We don't want to give alendronate in the context of a stricture. Her estrogen use, we're probably not going to put her on estrogen because of the cardiovascular risks. And then calcium and vitamin D, like I said, is a little bit controversial. So we would probably try to do it via her diet instead of giving her a supplement. So now we're going to do the functional assessment. So remember, for the healthcare maintenance of an elderly person, there's kind of two sections, right? So you're not just thinking about their cardiovascular risk and their cancer risk and their infectious disease risks like you do for other patients. There's also a whole section of functional assessment that you need to think about. And it has several different components. The first one is ADLs, which are things that can be activities of daily living that are done in the home. These are the things that toddlers learn how to do, right? How to feed yourself, how to clothe yourself, how to bathe yourself, right? How to use the bathroom. IADLs, on the other hand, are things that happen in the community. So these are things that teenagers learn how to do, right? Like how to drive and how to shop, how to pay bills, that kind of thing. Every patient should be assessed for cognition using one of these tools, the mini mental status exam, the mini hearing assessment, nutrition, and then the driving. Right. My woman who I was telling you about from before is not frail. She's 93 and she has an amazing prognosis. But if you have the exact same patient, only she's 68 years old, but now has these criteria for frailty, all of a sudden her risk for falls, disability, and death go way, way, way up. All right, so the criteria for frailty are unintentional weight loss of over 10 pounds in 1 year, exhaustion due to lack of endurance, and we see these people, right, where they walk and they just keep on needing breaks. They have a hard time getting out of their house to do things with their family members. Weakness, and the best way to assess this in the office is with this decreased hand grip strength, right? You can feel that people aren't holding on as well, and you can even see it sometimes with their walkers, that they aren't able to really grip. Walking slowly, right? So if it takes them more than 6 seconds to start walking to your exam room, then you should start worrying about assessing for this. And then reduced activity, all right? And this is something that sort of gives a number to this sense that we all already have about our patients, and I think it can sort of make you feel more confident in your clinical judgment for someone who's pretty high risk for a lot of adverse events. So falls, they are incredibly common. I hate these statistics. 25% of people at 70, which 70 doesn't feel very old to me at all, and then 50% of people at 80, right? So it's very common. It is very dangerous, especially in the context of a hip fracture. Remember that if someone fractures their hip, their mortality is 30%, right? It's a very morbid complication. So what are the risks for falls? So the most important one is prior falls. So the question you're going to ask your patient is, have you fallen in the last year? All right? Any answer other than no means that they're at high risk and that they need a further assessment. You can especially worry about your patients who have poor vision, who have an unsteady gait, if they have weakness in their lower extremities, much less if they're already in a wheelchair and they're trying to transfer themselves back and forth. There's a lot of medicines, which we'll talk about, that can make their risk even higher, cognitive impairment, and then musculoskeletal and cardiovascular diseases. I would add to this that some urinary problems where people have to get up and go to the restroom in the middle of the night when it's dark and they can't see, and maybe they don't have their walking implement, these people are very, very high risk. So the medicines, which ones cause falls? So the first one is benzodiazepines. Hypertensives in the context of orthostatic hypotension. Antidepressants, especially the tricyclics, right? Because of the allergic side effects that can cause people to be at increased. And then opioids. So the fall assessment, the best way to do it is to do some chair and cross their arms like this. Sit up and then walk across the room. And they should be able to do it in less than 12 seconds. If it takes them more than 12 seconds, then it means they're increased risk of a fall. And what you're going to do next then is observe them walking. And this doesn't mean just a normal gait. You also want them to do tandem and consider Romberg testing, because you're really trying to diagnose exactly what it is that's causing them to have difficulty walking. If it's weakness, then you will need to do strength training, right? If it's balance problem, then you can do gait and balance training. And then if it's orthostatic hypotension, where you see them stand up and then they get dizzy immediately, or if you find it on orthostatic vital signs, then that's when we really start looking through our medicines to see which ones could be causing this. And if we don't have a medicine that we can stop, then you can add compression stockings, good for all people always, or mineralocorticoids to kind of keep their blood pressure up. Finally, if they're immobile or bedridden, right, then they're going to have worsening muscle atrophy and osteomalacia, and this is when you can order physical therapy in bed to try to help maintain as much of their function as you can. All right, pressure sores, another important thing for these patients. This is just reminding you of the staging, all right? These often happen in holding their heels off of the bed, right? We always think about the sacrum, but you also have to think about the greater trochanters, the ischial tuberosity. I've seen people get pressure ulcers on the backs of their heads. So stage 1 ulcer means there's non-blanching erythema, right? So I get erythematous if I lean against this for too long, but it always blanches, right? So if it doesn't blanch, it's a stage 1 ulcer. Stage 2 means I've started to lose skin, but it's not all the way through. Once it gets through my skin, then it's a stage 3 ulcer. And then stage 4 means that you see the muscle, tendon, and bone. And the way we've diagnosed this clinically is usually with a probe to try to see how deep the ulcer goes. Remember that there's also an unstageable type of ulcer where it's black with an eschar and you can't see how deep it goes. And so in those cases, don't try to guess a stage. So how do we do it? So the most important thing is to prevent it and to keep pressure off of the ulcers. This is why we have these air mattresses that shift people slowly. This is why we have those boots that I was talking about earlier. Once you have one, then you really have to keep it clean. If there's necrotic tissue, it has to be debrided and cleaned. We don't use the wet to dry dressings as much anymore because they hurt so much, and a lot of times they pull off the healthy granulation tissue along with the necrotic tissue. There is vacuum-assisted negative pressure wound therapy, which can improve symptoms and seems to help the closure a little bit more quickly. We haven't been able to find much evidence that those. Hyperbaric oxygen is another thing that's sort of coming down the pike. It can be helpful, especially in patients with trauma and diabetic ulcers, but the exact utility of it is still unclear. And then always nutrition, right? So especially some of these micronutrients, things like zinc and copper and all of that stuff can cause a big problem for wound healing. Insomnia. So this is a very common problem in elderly patients. There are a lot of medicines that cause it that we can help them out by stopping. Caffeine, alcohol, nicotine, corticosteroids, a lot of the adrenergic things we give like beta blockers and beta agonists. There's also things like diuretics that cause them to urinate in the middle of the night that can make things much worse. The main thing we're going to do is sleep hygiene. So medicines for insomnia in elderly patients are generally contraindicated because of this risk of falls and confusion and delirium. So sleep hygiene, as you guys know, so no screens near the bed, right? That screen that I have my iPhone that I look at every night before I go to sleep goes directly to my brainstem and tells me that I should be awake and messes up with my circadian rhythms. The other thing is that when you lay in a bed not sleeping for more than 15 minutes, then it increases the way that your body thinks that it should be, what it thinks it should be doing in that bed. So after 15 minutes, I tell my patients, move to the guest room. Lay there for 15 minutes, move back to your bed. And honestly, I do that myself too, which is ridiculous, but I am an insomniac. It works great. The other things include no fluids after 5, no big meals in the evening, all of these kinds of things to help people get some better sleep. So the Z drugs, right? Benzodiazepines, zolpidem, all of those things. Like I mentioned, we don't need sleepwalking in our elderly patients, right? So better to stay away from all of them. The anticholinergic, the antihistamine, things like diphenhydramine, similarly can be very, very dangerous and can cause a lot of delirium. Some people use low-dose doxepin, that may be okay, and some people use melatonin or this Ramelteon, the melatonin agonist, that may be helpful, but the data is a little bit mixed on that. So, restless leg syndrome can be a common cause of insomnia in patients. It's another one that has sort of scary statistics. 20% of people over 80 have restless leg syndrome, and it can be kind of subtle with this leg discomfort and paresthesias below the knee at rest, which then worsen at night. The way that you're going to tell that this isn't something related to peripheral artery disease is that the symptoms actually get much better with movement. And it can be primary or secondary to things like Parkinson's disease. And the most important thing to do is to check for iron deficiency in all of these patients. There's a lot of medicines or interactions with caffeine, nicotine, and alcohol, so patients should avoid that completely. And then you can treat them with things like stretching. There's dopaminergic agents, pramipexole and ropinirole, that help, gabapentin, and then the iron. So if their ferritin is below 50, then just put them on iron supplements because it can help a lot. Some people use levodopa, but it can also cause these worsening rebound symptoms, unlike these other treatments. So, dementia and delirium. So dementia is chronic and progressive cognitive disease is the most common by far. It causes 80% of dementia. You can also have multi-infarct dementia, which is usually characterized by this stepward pattern, right? Where they say, my loved one was just fine, and then one day they were much more confused, and then they were fine for months, and then they got much worse, and it just keeps going down like that. That one will also have an abnormality in the MRI, right? You should be able to see the multiple events that caused this step-like deterioration. Lewy body dementia is also important to remember. This is a type of Parkinsonian dementia that is commonly seen with hallucinations and a little more sleep disturbance than classic Parkinson's disease. We have Parkinson's disease and then depression. And so when we get to depression, we finally have something that's reversible. And I think it's really important when you're evaluating for dementia to look as broadly. Things include hypothyroidism, neurosyphilis, which we see surprisingly often in Houston where I practice, normal pressure hydrocephalus, right? These sorts of things. And the other thing to remember, so that's whether it's progressive or not, right? Because if it's reversible, it doesn't need to be progressive. So there's also more acute cognitive deterioration, right, or subacute, and that's where you start thinking about Creutzfeldt-Jakob disease, right, which you're going to see with more myoclonus and things like that, along with the rapidly progressive pattern. So Alzheimer's disease. So if it's mild or moderate, then you can try these cholinesterase inhibitors and memantidine. They may help. They may delay the time until the patient needs nursing home care. But if it's severe disease, you're really going to start minimizing medications, minimizing interventions, start talking about goals of care and advanced care planning with the family, and just focus on sort of comfort and non-pharmacologic treatments. Remember that neuroleptics increase mortality. So unless the person is really at a risk to themselves or others, we're going to avoid all of those antipsychotic medicines in patients with dementia. So delirium, unlike dementia, is more acute and transient, right? So this is what we see. I see this all the time in my hospitalized patients where the residents go in and see the patient in the morning and they're like, oh man, they were really tired. And then I go in to see them at 10 a.m. and they're sitting up in bed eating breakfast and we have a great conversation about their grandkids, right? And then the residents always roll their eyes because, as you guys probably remember from training, everything always changes when the attending walks in the room. But so it's transient, right? It waxes and wanes. And somnolence is much more common than agitation, although we see both. And when you see a patient, an elderly patient with delirium, remember there's a broad differential diagnosis. I think we lots of times think about sundowning, but there's a whole list of things here. So systemic illness, especially infection. The classic thing is a lady who comes in, she's confused, and she has a urinary tract infection. But there's other systemic illnesses to think about, right? Electrolyte abnormalities. We already talked about hyperkalemia and hyponatremia, endocrine diseases like myxedema, coma, and things like that. Medications, so we've been talking about that a lot. I would add on top of medications is toxins, right? So there's things like alcohol and other things that can affect elderly people just like younger people. Surgery, especially when complicated by uncontrolled pain, can really disorient patients. And then any kind of restraints, whether that's telemetry or bladder catheters or sheets tangled around their legs, right? All of these things will make a person much more disoriented and unclear where they are. And then finally, at the end of the list here, we have sundowning, which is just delirium at nighttime that's related to being in an unknown situation. You know, it's like when you wake up in the hotel room and you're at a med study conference and you're like, where am I, right? What am I doing? Which happens to me also frequently. So managing delirium, just like the pressure ulcers, it's all about prevention, right? If you can't prevent it by having a family member at bedside or have someone go in and reorienting the patient, then you're going to make sure that you always search for an underlying cause and stop all medicines, right? Especially the ones that are psychoactive. You reorient them, you avoid restraints because it's only going to make it worse. You avoid neuroleptics because it's going to increase their mortality, and then we're really not going to use benzodiazepines or any other anticholinergic medicine to try to kind of keep the patient from being more agitated. Infections in the elderly. So catheter-associated UTI is very common. Remember that a lot of times this is going to be a colonizer, so you're really going to treat only in patients with symptomatic infection. You're going to remove the catheter, start treatment. You can do intermittent catheterization, and then once therapy is started, if you need to, you can put the catheter back in. But in general, we want to really remove them as much as possible. So how do these infections present? So they present with falls, they present with delirium and failure to thrive. This is just a chart that I think is so interesting that shows the way that the elderly present with pneumonia versus young patients. So the elderly patients come in with mental status change, falls, failure to thrive, tachypnea and tachycardia, more than fevers, right? So the young people come in with the fever and cough sputum that we think about all the time. Also, remember that if patients coming in from a nursing home, then the organisms you're going to find in their pneumonia is completely different. So pneumococcus becomes much less common, and gram-negative rods take over 40 to 50% of infections. This is especially pseudomonal infections, which is why we often use things like ceftazidime, cefepime, piperacillin, tazobactam right off the bat for patients who are coming in with from a nursing home with a healthcare-associated pneumonia. Anaerobes can be a problem, especially if the patient has teeth and is chronically aspirating. Staph aureus is important, especially because of MRSA, right? Methicillin-resistant Staph aureus. So we use vancomycin often along with our anti-pseudomonal antibiotic when patients come in from nursing homes, and then tuberculosis. So that is very common in institutionalized settings, unfortunately not just prisons. So now we have a few more audience response section. The first one, a 76-year-old woman is brought in for evaluation of several recent falls. She lives in a nursing home. She spends much of her day in bed, getting up for lunch and dinner. She has type 2 diabetes, hypertension, coronary artery disease, and reflux. Her meds are omeprazole, nortriptyline, hydrochlorothiazide, and calcium with vitamin D. In addition to exercise training, which would you recommend? Good, guys, I told you, always just stop the med, right? So we didn't see physical therapy on the list, but that would be our second choice if we didn't have an option to stop nortriptyline. I think here with the first two questions, they're trying to get at whether her falls are related to a cardiac cause of syncope, right? Remember that syncope is very different from fall, and that's why it's so important to find out if someone lost consciousness in the context of their fall. Alendronate may be appropriate, but first we need a FRAX score to be able to calculate like we talked about before, and then soft restraints are pretty much never going to be the choice, especially on a standardized test, but even in general. A 72-year-old woman reports discomfort in both of her lower extremities. The discomfort is present when she is seated, occurring in both calves. It improves when she is walking. She describes it as a deep ache, sometimes with an itching or pulling feeling. She has increased symptoms at nighttime when she is in bed. She has a history of diabetes and hypertension. Her meds are hydrochlorothiazide, lisinopril, and metformin. Her exam is unremarkable. What is the most appropriate test? Good, iron studies. So she seems to have problems with movement that actually get better when she walks. So we aren't very worried about peripheral artery disease, right, which would be the most common thing when we first hear about lower extremity pain in an elderly patient. And so we're going to check iron studies and see if what her ferritin is. If it's over 50 or under 50, then we're going to go ahead and start iron supplements and see if that helps her with her restless leg syndrome before we have to start anything more intense. So now her labs come back normal. Her ferritin is 80, her creatinine is 0.9 milligrams per deciliter. What is the most appropriate pharmacologic therapy? Good, pramipexole, perfect. Topiramate is a possible choice, but we would probably start with pramipexole or one of the other medicines that's a little bit more focused before we start that. We aren't going to do ibuprofen, obviously, because of the risk of kidney disease and hyperkalemia in that. Felodipine is not relevant. Oxycodone is pretty much never going to be an option in an ambulatory patient if you can avoid it, just because of all of the risks associated with opiates. A 78-year-old woman is admitted with a perforated duodenal ulcer. She has surgery and is moved to the ICU. After removal from the ventilator, she is extremely confused. She does not know where she is or who she is. She keeps trying to get out of bed, but calms down with reorientation. So what would be the best way to manage this patient? Good. Excellent. I wonder who the 1% is. Sorry to whoever. They probably got confused with the button, right? That must be it. Sorry, I told you guys, never any restraints. Haloperidol is going to increase risk of mortality. Lorazepam is going to increase delirium and falls. Always a sitter. If you can't stop a med or send a PT, then get a sitter. You're called to evaluate a 74-year-old man with Parkinson's disease. He's been hospitalized twice in the last year for urosepsis. Because of incontinence, he's required a chronic indwelling urinary catheter. He's currently afebrile and has no abdominal pain. He has had no mental status changes or recent falls. His labs 48 hours ago include a white count of 8,000, a hematocrit of 42%, sodium 137, potassium 3.6, BUN 20, creatinine 1.2, and a urine culture showing more than 100,000 colonies of Enterococcus. What therapy do you recommend? Perfect. No therapy at this time. So this is a colonizer in a patient with a chronic indwelling Foley. I think that some of these other treatments, especially ampicillin, would be very appropriate otherwise. But you'd have to see something like leukocytosis or increases in falls or delirium or something like that to make you think that it's symptomatic so that you would decide to treat it. All right. A great lead-in, once again, to urology and sexual health. So urinary incontinence is kind of a complex procedure, although it's a complex mechanism, although it's very common. So you have to have an appropriate cerebral cortex and brainstem function. Your sacral nerve, which is S2 through S4, needs to work, and then your bladder muscles, which include both the detrusor that causes the contraction of the bladder and the sphincter muscles that prevent the bladder from emptying inappropriately. So based on this mechanism, there are specific types of urinary incontinence, right? So the first one is incontinence due to reversible causes, right? So this is something like a diuretic or a urinary tract infection or a kidney stone or something like that. Then there's functional incontinence, which means you're incontinent just because you are unable to get to the bathroom or you don't have appropriate cortical function to be able to do it. And then finally, your lower urinary tract causes, right? And here's the set. So urge incontinence basically just means that the detrusor is overactive and your bladder starts to squeeze before you're ready for it to. For stress incontinence, it's that the sphincter doesn't work, right? So the sphincter can't hold the urine in, and so when there's pressure for any any reason in the abdominal cavity, then there's leaking. There can also be overflow incontinence, which basically means the bladder is so distended because the detrusor isn't working at all that it basically leaks sometimes just because it's so full. So that's called overflow incontinence in the context of neurologic disease. And then mixed incontinence, which is very common, and we see it in a lot of these different patients. So the types of urinary incontinence, this is just a little bit more detail on that. So remember, there's UTIs that can be diagnosed by a urinalysis, and you can always give antibiotics for that. Atrophic vaginitis is incredibly common in elderly women, and you can find it on exam and treat it with topical estrogen. There's either a cream or a ring. The ring is better because there's less absorption of the estrogen medication into the system. Pregnancy or vaginal delivery. Episiotomy, this is a common cause of urinary incontinence that resolves over the course of the year afterwards. Post-prostatectomy, also usually self-limited. Stool impaction, very common in nursing home patients, right? When the rectum becomes increasingly distended, then the bladder is unable to function well. And then medications, as we've been talking about a lot. The drugs that cause this urinary incontinence, like I mentioned, there's diuretics, right? Because they cause polyuria, frequency, urgency, right? The bladder gets over full and then the detrusor starts spasming. Caffeine can also aggravate it, both because it's a diuretic and because it increases the spasms of the detrusor muscle. Anticholinergics impair directly with the ability of the bladder to function, and so they can cause retention of the urine. Sedatives. So sedatives can cause muscle relaxation and incomplete bladder emptying, and then opioids, right, for the same mechanism as above. And even more, so alpha blockers or agonists, right, as we discussed, whether if you relax the urethra, then you're going to have stress incontinence. If you cause the urethra to be too not relaxed enough, then you're going to have urinary retention and overflow incontinence, right? Similarly, beta blockers and calcium channel blockers all work through the same mechanism. And then alcohol is a big offender because it's similar to caffeine. It's a diuretic. It causes frequency. It causes sedation. Even young people can have urinary continence in the context of alcohol overuse. So a cute little acronym to help you remember the reversible causes of urinary incontinence. DRIP, right? So drugs, resisted mobility, infection or impaction, and then polyuric states like hyperglycemia, heart failure, alcohol abuse, all of that stuff. So just a little bit more into these types of urinary incontinence. So the first one is urge incontinence. So this is the one where the detrusor muscle spasms and it's overactive. So even with a low volume of urine, it all of a sudden starts trying to empty the bladder. And in this situation, the sphincter is not going to be able to counteract what the detrusor is doing. So the way it is that the patient gets a sudden urge to use the bathroom, starts going for it, but the bladder empties before they reach the toilet, okay? So the idea is that there's a little bit of a delay, though, between the urge and when the emptying happens. With stress incontinence, on the other hand, it's just a weak sphincter. And so in this context, as soon as the intra-abdominal pressure increases, a leakage happens. It's almost immediate in the context of a cough or a sneeze, right? Something like that. Jumping, laughing, standing, all sorts of things like that that just cause sort of low volume urinary loss, as opposed to urge incontinence where usually the whole bladder empties and it's more large volume. Mixed incontinence means there's features of both. This is incredibly common, as you can imagine. And then overflow incontinence, basically, the idea is that you can either have outlet obstruction or neurologic problems that cause the bladder to get bigger and bigger, and then you're just going to basically have these small volume leaks, just like you do for stress incontinence. Although there can be aspects where when the bladder gets very distended, then the detrusor muscle spasms. So this is often a cause of mixed incontinence. So how do you treat it? So bladder training is incredibly important. This is where you have your patient get their phone. I think there's even apps that can do this, and they set a timer to void every 15 minutes, whatever they can do, as short as they can do. They empty their bladder and their detrusor muscle starts calming down. Over the course of several days, they can increase it, right, from 15 to 30 minutes, 30 minutes to an hour, right? And slowly, eventually, they train their bladder to just calm down, right? That they're going to get to the bathroom eventually. So that's bladder training. It can be useful for urge, stress, or mixed incontinence. Kegel exercises are important for everything, right? So this is a way to get the sphincter a lot stronger, and it can help urge, stress, or mixed incontinence, but especially stress incontinence. You can even have people go to pelvic physical therapy to learn Kegel exercises, where a therapist can work with them to help keep them accountable and learn what they're supposed to be doing. The drugs, there's also drugs for urge and mixed, but the problem is that, as you can imagine, if you give them a drug to help with urge incontinence, it causes an increased problem with urinary retention, right? So you can give anticholinergics like oxybutynin or tolterodine, although we've been talking so much about all of the risk of falls and other problems with those medicines. There's also beta agonists that can help with that. Surgery can be helpful, but only as a last resource for stress incontinence, right? And so they'll do a urethral procedure to sort of hold it up against the pelvic wall a little bit better to allow that sphincter to be a little stronger. We really don't use drugs for stress incontinence because it really doesn't make a difference. And then overflow incontinence is really all about the underlying cause. And if you can't reverse the underlying cause, such as prostatic hypertrophy or something like that, then you're going to move towards intermittent catheterization, right? And these are the patients with chronic neurogenic bladder who do straight catheterization for themselves. Erectile dysfunction, what causes it? The most common etiology is vascular. So this is going to be patients with diabetes and hypertension who also get, leg pain when they walk too far and then come in with erectile dysfunction. You can also have that same patient who has erectile dysfunction for neurogenic reasons, right? Only in that patient, usually they'll have peripheral neuropathy, tingling in both extremities that sort of has worked its way up above the knees to the thighs. Hypogonadism can also be a problem, and usually that is in the context of low libido along with the erectile dysfunction. The top two really do have very normal libido levels. And then medication. So unfortunately, we cause this problem for a lot of our patients with things like our beta blockers for coronary artery disease, a lot of the antihypertensives, and then serotonin SSRIs, which can cause problems in multiple ways for sexual function. And then finally, psychogenic. So this is usually in the context of a specific partner or some sort of episode of depression. It can be very acute onset, and one of the main things that you can find to distinguish it is the patient often will have normal morning erections and then just have trouble when they're with a partner. So how do we treat it? As you guys probably know, the PDE5 inhibitors are the most common treatment. This is sildenafil, vardenafil, tadalafil, and avanafil. The biggest problem is trying to get it covered by insurance companies, and also all are contraindicated with nitrates. So we just said that coronary artery, or that peripheral artery diseases is the most common causes of erectile dysfunction, and so these patients are not able to get nitrates. It's very important to tell them if you get chest pain after taking one of these medicines, you have to tell the ambulance that shows up that they can't give you nitrates. It can cause severe hypotension. Sildenafil also has this interesting cross-reaction with the PDE6 in the retina and causes blue vision, which your patients will come and talk to you about because it's quite disturbing from what I hear. You can also get hearing loss. Tadalafil causes back pain, and tadalafil is actually having an increasing use for benign prostatic hypertrophy. All of these medicines or at least sildenafil, and I think most of them at this point are also used for pulmonary artery hypertension in different doses. There's other options, though, too, for patients who can't take the PDE5 inhibitors. One of them is the vacuum device, which is safe but inconvenient and doesn't always work. There's intraurethral alprostadil, which is safe but obviously uncomfortable, along with the penile injections. And then finally, there's penile implants, which you should really only use after all the other therapies have failed, just because of the risks of surgery. Other sexual dysfunction, so dyspareunia, pain on intercourse for women, is usually due to atrophic vaginitis in an elderly woman, and so you can treat with either a lubricant or estrogen. And as we mentioned before, the ring is better than the cream. The cream is very goopy also and very inconvenient for the patients. I found adherence to be incredibly low with that medicine. And then decreased libido. So this can be related, like we mentioned, to hypogonadism or the meds, right? The SSRIs. And it's very difficult because a depressed patient also has a low libido. And so then when you give them an SSRI, now they have a low libido, right? And so this can be a reason to switch to something different, something like bupropion that doesn't have so many sexual side effects. And the other thing to remember about SSRIs is often the patient will have a normal libido, but a delayed orgasm or anorgasmia. It's been reported up to 30% of patients on these medicines. Benign prostatic hypertrophy, so hyperplasia. Over 80% of men over age 85 will have BPH. It usually presents with these classic lower urinary symptoms: polyuria, incomplete emptying, nocturia, right? One of the main things that we can measure to see if our medicines are working or not is how many times the patient has to get up at night to urinate. You have to think about other things, though, and it's hard for these very, very common diseases. It's so easy to just get this sort of monosynaptic reflex to just assume it's BPH, but this can also be related to bladder cancer, cystitis, prostatitis, or prostate cancer. So the patients really all need a digital rectal exam to make sure their prostate is normal and a urinalysis. You don't necessarily need to do a PSA or a creatinine unless there's evidence that a patient is having problems with retention, or there's something about the story or the exam that makes you more concerned for prostate cancer. And you're going to start with behavioral therapy. And so this is something like bladder training, where someone is, trying to increase the amount of time they can go without urinating, decreasing the amount of fluids that they take at night, decreasing diuretics at night. If that doesn't work, then we move to alpha blockade and 5-alpha reductase inhibitors, so doxazosin, tamsulosin, and finasteride, and you can use these together or separately, but you still have to watch out, right? Because if you give an alpha blockade to a man over 85, then you're at risk of falls. And once you give a 5-alpha reductase inhibitor, right, which it decreases the amount of androgen that's down for the man, you can cause sexual dysfunction. So testicular abnormalities are a common presenting problem in primary care practice. If it's painful, then it's emergency, and then it's an emergency, right? It can be something like torsion of the entire testicle, right, where you usually have one testicle that's higher than the other one, or it can be just a small blue dot that means there's torsion of the testicular appendage. You can also have epididymitis or epididymoorchitis. This is important. It can be related to a sexually transmitted disease or just a gram-negative bacteria. And then a hematocele. This is common, especially after trauma, that someone would come in with a hematocele causing a painful testicular mass. If it's not painful, then it's not an immediate emergency, but it can still be very serious. So things like hydroceles we don't worry about as much. This is the one that transilluminates. The varicocele, where you've got like this bag of worms sort of appearance, right, which is just caused by increased vascular dilation. It can always be a hernia, so you can find that usually on exam, or by having the patient increase their intra-abdominal pressure and seeing if it changes. And then testicular cancer. So remember, testicular cancer is something that usually affects men in a much younger age, in their 20s to 30s, but you really need to consider it in everyone. And then finally, skin cysts, which are very common also, that a man will come in with a testicular mass, and it'll be something that's related to the skin. So we have some more audience response questions. The first one: a 79-year-old woman reports problems with urinary incontinence on a daily basis. She has to void many times during the day and leaks urine frequently before she can get to the restroom. She has not had hematuria or dysuria. Her medications are omeprazole, sertraline, and enalapril. Her urinalysis is normal. What is the most likely cause of the incontinence? Good. So detrusor overactivity. So this is urge incontinence, right? So the detrusor is pushing out the urine before she's ready for it. The second one that you guys chose was sphincter dysfunction. So this is stress incontinence. So the difference here is that she would be leaking urine when she coughs without having to try to get to the bathroom, right? Detrusor underactivity is also a good guess, right? So that would suggest that she has overflow incontinence, but there would usually be something in the story about, a neurologic cause or something else that could be blocking it. And then a side effect of sertraline and enalapril, it's always important to consider side effects, but these aren't usually associated with these medicines. A 76-year-old woman is evaluated for urinary incontinence. She reports a 6-year history of incontinence occurring when she laughs, coughs, or sneezes. Recently, she has had incontinence with standing. Her urinalysis is normal. Her BUN is 14, creatinine 1.1, and glucose 111. What would you recommend? Perfect, good job. So Kegel exercises are the main treatment for stress urinary incontinence, which is what she has. The other medicines might help her if she was having a problem with urge incontinence, but we're always going to try Kegel exercises first in most cases, and bladder training if it did turn out to be urge incontinence. A 76-year-old man presents for evaluation of urinary frequency and decreased urinary stream. The symptoms have been present for the past 3 years, but have worsened over the last 6 months. He's now getting up 4 times a night to urinate. On exam, his prostate is 3+ enlarged without nodularity. What do you recommend for short-term relief? Bless you. Good, tamsulosin. So part of the key here is short-term relief, right? So remember, tamsulosin, because of the alpha activity, is going to cause immediate muscle relaxation and help him almost immediately. This is why we use it for people who come in with nephrolithiasis in the hospital, and it helps so substantially. Finasteride would work over the long term, right? And then we would have to decide on PSA testing for him. I think a lot of people would consider it in the context of getting much worse over the last 6 months, even though his prostate exam is normal. A 74-year-old diabetic man reports increasing problems with sexual functioning. He reports normal sexual desire, but inability to sustain an erection sufficient for intercourse. It has been slowly worsening over the past 3 years. Testicular and prostate exams are normal. His medicines are metformin, insulin, atorvastatin, ranitidine, and ginkgo biloba. What is the most likely cause of his erectile dysfunction? Good, vascular disease, exactly. So overall, even if we didn't have the previous slide at all, the most likely cause of erectile dysfunction is vascular disease. So you're really going to be looking in the STEM for something to make you choose something else, right? And in the context of a normal desire, the low testosterone levels are really unlikely. They would have to give you something like that he has noticed that he no longer has morning erections. Number 20, a 67-year-old man presents for treatment of erectile dysfunction. He has had problems sustaining erections for the past year. He has normal libido. Testicular and prostate exams are normal. His medicines are simvastatin, omeprazole, isosorbide mononitrate, lisinopril, and aspirin. What would you give him for therapy? Good. So the answer is intraurethral alprostadil. Sildenafil would be the classic first choice, but the problem is that he's on isosorbide mononitrate, right? So if we give him the sildenafil, it's going to cause a decrease in his blood pressure. And there's lots of tricky ways for people to be on nitrates that you aren't really aware of, right? They can be on a long-acting nitrate. Like I mentioned, they can need one urgently when an ambulance shows up. They can take one from their friend when their chest hurts, right? So there's lots and lots of mechanisms by which someone can get to this very, very dangerous hypotension, and it's important to recognize what is the cause of it. Let's see the other answers here. Testosterone patch. That's an interesting choice, especially in the context if he had a low libido, but we probably wouldn't reach for it in this situation. And then referral for a penile implant. I think if the patient was amenable, we would do a topical treatment first before going to surgery. All right, ethics. So let's start with principles of physician-patient interactions, or these are like the 4 pillars of ethics. When we teach it to medical students, the first one is respect for patient autonomy, helping patients to make free, non-coerced choices. So this is part of something we value very highly in the United States, but is something that is not necessarily valued throughout the world. We really feel that everyone should be able to be a complete individual. The second one is beneficence, right? So to do good things for the patient, to do your best to help them, right? The second one is sort of the flip side of that coin, non-maleficence, which means you don't hurt them, right? And then finally, justice, which is equitable care for all patients. And justice can be related to socioeconomic status. It can be related to geographic differences, gender differences, everything. And so these 4 principles really interact throughout all of the ethical questions that we think about, and they often come in conflict, right? Like, you're trying to give a patient a stem cell transplant, which would help them with the principle of beneficence, but it also could hurt them and cause them harm, right? And so it's an ethical problem of what you should do. And we'll talk through those as we go. So autonomy can come up in a lot of situations, commonly religious differences, right? So remember that we err on the side of respecting autonomy in almost all of these cases. So religious differences, we do not force adults to receive care if it's contrary to their religious preferences, as long as the adult has full capacity to make that decision, right? And we'll talk a little bit more about what goes into having capacity. Number 2, pregnant women, right? So pregnant women, depending on the state, usually cannot be forced to have care for themselves or their baby. And this means in a lot of settings, even if they're in delivery, and you want to do like scalp monitoring of the baby, if the mom says no, in a lot of places we respect the autonomy of the mother over that of the baby. For paternalism, so this is something that happens a lot in all sorts of other cultures, and I think in our practices also, where we don't ignore, but we override the patient's preferences in order to enhance their welfare. So in this situation, we're saying beneficence is more important than autonomy, right? And I think in the current healthcare setting, we're trying to stop doing that, right? And really respect their autonomy to even make choices that are not in their best interest. That they really need to be active participants in the decision-making process with the idea of informed consent, right? And informed consent is a really complicated process where you both have to inform them and then they have to consent and make a choice. And you have to inform them of all the potential side effects, everything else that they could do, right? And then they have to show that they understood that and then consent. And many times we need to document that entire process to prove that we correctly informed them and got their consent. So capacity, it refers to the act of comprehending, evaluating, and choosing among realistic options. So, you have to be able to understand it and repeat it back. You have to be able to evaluate it and often show that you have some sort of logical framework that you're using to make decisions, right? And then you have to choose. So part of capacity includes being able to indicate your choice. So if you can't speak or you can't write or you don't have a healthcare proxy, right, then you don't have capacity no matter what actually your cortical brain function is going. It's different than competency, right? So I can have competency to examine someone's heart, but I might not have capacity to make a choice for myself if I have encephalitis and am refusing a lumbar puncture, right? And similar, so if a patient can't make that decision due to the incapacitating illness, then we pick a surrogate or a proxy to make the decision. And if the patient hasn't specified who they want, then it's specified by state law. And it varies depending on whether you're consenting to give care or consenting to remove care, depending on the state, but it usually goes something like spouse, followed by parents, followed by children, followed by siblings, and then it becomes next available family member, and then it often will go to people like clergy members. If the patient has used a durable power of attorney document to specify their preference, then that preference supersedes the family every single time. And that person actually will be able to make decisions as if they were the patient in all settings, including withdrawal of care and everything like that. The important thing for a surrogate to understand, especially if it's not a power of attorney, it's just a family member who's getting pulled into this, is that they're representing what the patient wants, not what they would want or what they want for the patient. This can be very freeing to people, obviously, because you don't want to make the decision to take life support off of that person because you want them to stay alive in life support, but you know that they wouldn't want to live like that, and then that's how the withdrawal is able to happen. The other thing that I didn't really talk about much is this decision-specific aspect of it. So this is especially important in mental health and mental illness. So if I have anorexia, then I might have capacity to make decisions about all sorts of things in my life. And if I come in with sinusitis, I can agree to take antibiotics, but I don't have capacity to make a decision about whether I eat, right? And so it's really important that for each decision, you figure out what it is that, whether they have all these things, whether they can comprehend, evaluate, and choose in all of these different situations. So an advance directive is similar from a power of attorney in that it is a document, right? So it's a way for them to direct their healthcare in case they lose decision-making capacity, but it's more focused, right? So you can say, I never want to be intubated. I never want to get antibiotics if I have dementia, whatever it is. But then if I get acute encephalitis, then people don't know how to incorporate my living will into my preferences. And this is where things can get messy, because if my family disagrees with my living will and someone finds a loophole where, maybe I didn't specify exactly what I would want in this situation, or maybe my mind has changed since I did my living will 10 years ago, the living will is much weaker compared to a power of attorney who can function on my behalf. So it's really important that the durable power of attorney knows what's in a living will so that they don't accidentally counteract it, and that the family really understands the role of the durable power of attorney in this situation. So in an ethical dilemma, there's a very specific approach. First, you clarify the ethical issues, right? So you're going to think about these 4 things: autonomy, beneficence, non-maleficence, and equality. And you're going to figure out which one weighs in on each side of the issue. And so you guys can imagine how this would go with something like physician-assisted suicide, right? We want to respect the patient's autonomy, but that's in conflict with non-maleficence. And how does justice play into this, right? And whose justice are we talking about for people who maybe have different abilities in the world, right? And so you're figuring out which ones are in different places and which ones are at stake. And then you're thinking about it culturally in the context of a human being who has, a different worldview maybe than we do. And then that's how you can make a decision. If you still don't know what to do and you don't have a legal rule to help you, you can always call an ethics consult. I don't know if you guys have called these in your hospital. They're very slow because you call in all of these very thoughtful people, and they sit around in a room and they think really hard about what's going on, and it's wonderful, but it can be very slow. So if it's the middle of the night and you're trying to decide whether to give someone antibiotics, it can be challenging, right? And that's why a lot of times this sort of emergency rule takes over, and if we don't have a clear indication that the person doesn't want it and the healthcare proxy isn't around and we don't know what to do, we often will stabilize the patient with whatever means necessary and then call the ethics consult later. And then a court decision. So this is something that's mandated by law quite frequently for things like, in order to give a patient antipsychotics long-term in a facility, we have to have guardianship through the courts, and it takes months. I have patients living at our hospital at LBJ in Houston. I don't know if any of y'all are from Houston, but they live there for hundreds of days, right? While we're waiting for guardianship. And then when they come back with an infection, trying to get in touch with the guardian and everything else is very, very, very difficult. And I think that the important thing to think about this also is how it relates to our last section on the elderly patients, right? We have this long list of things we're supposed to be doing with all of our elderly patients. At the bottom of it should really be medical power of attorney, right? So that all of our patients, as they develop dementia or whatever else, that we know who to call for them and that they already have that documented for us and for their own safety, and because it's really horrible for families to make these decisions in the absence of any guidance. So confidentiality. So obviously, confidentiality is very important. It allows our patients to be honest with us, especially about very sensitive topics. And we have a lot of stature in society that allows us to get these the specific things out of patients. If we break that by going to the press or posting on Twitter or Instagram or whatever else about our patients, then it would cause a huge problem. But there are some times when we are actually required to disclose. The first one is obviously if they're planning to hurt themselves or others, especially if it's a named individual, we really need to call the police. There are laws that we have to call the police, let them know what's going on. It can vary by state, but I think we can all agree that we will be more comfortable doing that anyway. It's a little more complicated if I have a patient who is doing something that is chronically putting someone else at risk. So something like HIV status or sexually transmitted diseases or, dangerous practices. And so usually we don't do sneaky stuff like, the next time the patient come in, just like bring it up or like act casual and be like, we test everyone for neurosyphilis, right? We make sure that the person is notified, and this happens through the public health department. I actually, when I was a resident, I worked in the Massachusetts Department of Public Health, and they had this whole room full of people, and they had this Public Health Department of Massachusetts Facebook page, and they would go in and find the sexual partners of everyone who we were dealing with and like send them these very scary, I don't know, it seems like it'd be very scary to get a message from the Massachusetts State Department of Public Health saying that you've been exposed to syphilis or gonorrhea or chlamydia, but the Department of Public Health will handle that so that way we don't have to. Physician-patient sexual relationships, okay guys, they are inappropriate. We already know this, but we'll say it. If they do put up some question about how you would go about having a romantic relationship with a patient, then the way to handle it is to terminate the professional relationship and wait a period of time. This is not just for the direct patient, but for all of their family members, all right? We don't want to have any sort of conflict of interest. And it also matters when you're talking about calling in prescriptions for your family members or your loved ones and all of that stuff. I think the other thing to remember that's related to this in the current era is talking about having people in the room during sensitive parts of the exam. I think that all of us are, very visible in our communities, and when we're alone with patients, we make ourselves vulnerable to anything that they could say about what could have happened in there. And so that's why in our clinic we pull MAs and medical assistants in with us very, very frequently. Disclosure of medical errors. So medical errors should be disclosed if we think that it impacted the patient in any way. So if I put in an order for Dilaudid instead of morphine and I delete it immediately, then I don't have to tell anyone, right? But if it does go to the patient, especially if I have to do something to counteract it, right? If I give them double their antihypertensive and then their blood pressure is low and I need to give them some fluids, it's my responsibility to tell them, right? And there's data that we really aren't any more likely to be sued. Just because you disclose doesn't mean that you're going to be in trouble. And it shouldn't matter whether the patient's more or less likely to catch you. It doesn't necessarily mean that you're negligent, right? So I can even say, I gave you too much insulin because I thought it was the right dose, or we gave you more insulin than you could tolerate. We thought you would eat lunch and you didn't, and we had to make you NPO. So it doesn't mean that I'm negligent or unethical, but if I don't tell them, then I can be held responsible for that. So the other thing is that patients really want us to disclose, and I think that it's important to know that often they can increase their trust of us by knowing that we're being very straightforward with them. And then the other thing that can be very helpful, especially if you're disclosing something that's a little more difficult, is to go in there with a health administrator, with a patient advocate, and talk about all the things you're going to do to make sure that that error never happens in your clinic again. And often patients can actually be quite inspired by that to try to help in that process and bring them in to do quality improvement activities and other patient safety type things. So now we get to do some audience response questions. The first one, a 29-year-old woman presents with hematemesis. She's found to have a hematocrit of 20%. She receives IV fluid and is typed and screened for transfusion. A repeat hematocrit 2 hours later is 14%. The patient refuses the blood transfusion when it is brought in because of religious convictions. Her husband, who's in the room with her, supports her stance. She has another episode of hematemesis during the discussion. What would you do? Good, exactly. So we have a patient who seems to have full capacity. We also have a healthcare proxy in her husband. So even if we didn't think she had capacity, he agrees with her, right? And so she doesn't get blood, right? And in fact, it would be considered assault to give her blood anyway, or to sedate her and give her blood. If there was no healthcare proxy in the room, right, then we would have to assess her capacity more thoroughly and make sure that she understood what was going on. I think the only time that we would do this is if she came in and she had no capacity and no healthcare proxy, right? And I think the ethics consult would be if she had no capacity, she had her husband in the room, but then it turned out that she also had a common law husband and she'd been separated from her husband in 7 years and you're not sure what to do, right? Then you would give blood and then call an ethics consult. All right, a 21-year-old college student is brought to the emergency room by her roommate for symptoms of headache and fever with stiff neck over the past 18 hours. On exam, she's somnolent but arousable with a temperature of 102.2, blood pressure 100/52, and heart rate 112. Nuchal rigidity is present. The remainder of her exam is unremarkable, and her white count is 24,000. The patient gives consent for a lumbar puncture. You order a stat dose of IV antibiotics, which the patient overhears. She becomes agitated and refuses the antibiotics. You carefully explain the high risk of death from untreated meningitis. The patient continues to refuse antibiotics and is more agitated. What should you do? Good, exactly. So she has questionable decision-making capacity. She's not able to repeat back to you why she thinks that she wants to refuse the help of these antibiotics in the context of her meningitis. And also it doesn't make any sense why she agreed to the lumbar puncture but not the antibiotics. It suggests she doesn't understand what's going on. So in an emergency, we would treat her with antibiotics. Now, this one with the patient's roommate, the roommate is never her healthcare proxy, right? So I think in some cases you might call the parents and just be like, just so you know, she's refusing antibiotics, we're gonna give them anyway, just in case they say, there's actually some reason that she's allergic to ceftriaxone, right? But the roommate doesn't have any legal authority in this situation at all. And then an urgent court order doesn't exist from what I know. A 44-year-old woman presents to clinic upset because she was found to be HIV positive at a recent health fair screening. Her husband, also your patient, doesn't know about her HIV status, and she refuses to tell him because she is afraid that disclosure would destroy their marriage. HIV is a reportable illness in your state. In addition to encouraging disclosure, what should you do? Yay, glad you guys got it, because I basically gave it away with my long Massachusetts story. But yeah, so you'd report her illness to the health department and they would contact the husband. I think it can be a little bit more complicated in things like HSV infection and things like this that aren't necessarily reportable, but in this case, it's very straightforward. All right, an 86-year-old woman who lives in a nursing home is admitted with severe aspiration pneumonia. She's unconscious with a fever of 104, ABG 7.22, 5266. She's been started on IV antibiotics and fluids. Her nephew is the durable power of attorney for healthcare. The patient has never completed a living will or advanced directives. The nephew meets with you, stating that his aunt has become demented over the past few years. The nephew would like IV fluids and antibiotics discontinued with comfort measures only. You understand that there's a son also present. Which of the following statements about the nephew is true? I'll read them just because they're long. A, because the patient has not left specific advanced directives, instructions to discontinue IV fluids and antibiotics should not be carried out. B, the patient has a son who is next of kin and therefore the nephew can't make medical decisions for her. C, the nephew's request to discontinue IV fluids and antibiotics is within his capacity to act as the patient's durable power of attorney. Or D, the nephew's instructions can be carried out only if it is determined that he had discussed the specific situation with his aunt and is carrying out substituted judgment. C, exactly. So as a durable power of attorney, he has all of the capabilities that the patient herself would have, and he's allowed to request that. I think for A, the answer would make more sense if she had an advance directive or a living will instead of a durable power of attorney. In that situation, if she said something like, I don't never want to be intubated, or things like that, then we would probably still give IV fluids and antibiotics because she never specified. If she did not have an appointed medical power of attorney, then the nephew would not have any status legally in this situation. And then the last one, we never try to ask them about this specific situation. I think legally that's come up in the past with some of these sort of big cases related to withdrawal of care, but in our practice, it's not really relevant. All right, a 56-year-old man with type 2 diabetes is hospitalized for treatment of cellulitis. He is given 100 units of NPH insulin instead of the 10 units that he usually takes. This is discovered 10 minutes after he receives the dose. He is placed on a D10 drip. What should the physician tell the patient? Perfect, good. So we just tell them the truth, right? And most patients actually can handle it pretty well. I see there were a few people that talked about it down here. I think, he's always going to wonder, well, why am I developing low blood sugar, all that, and people can usually tell. So I think it's the best ethical principle is to just disclose. All right, the first thing to talk about is pre-op cardiac risk assessment. So this is, the patient is going for surgery, and you're trying to decide what their risk of a major cardiovascular event is during that procedure. And there's basically 4 questions, just a flow sheet, you go straight down. The first thing is this emergency surgery, right? So if I come in with an intracranial hematoma, nobody's gonna ask anything about my heart before they go drain it, right? Because it could save my life. But let's say it's not, or an appendicitis, right? Let's say it's not an emergency surgery. So then we go down to question 2. Does the patient have acute coronary syndrome or some other active acute cardiac event, right? And so this could be something like an ST elevation MI. This could be acute decompensated heart failure, decompensated valve failure, an acute arrhythmia. Like, no one's going to take a patient with, atrial fibrillation with rapid ventricular rate directly to the OR without dealing with these things. So similar to the way that emergency surgery, you go straight to the OR, an active cardiac event, you go directly to cardiac management before you go to the OR, right? If neither of those 2 things are going on and the patient is fairly stable, then you estimate their risk of MACE, which is a major adverse cardiac event. And the way we do that is through the RCRI, or the Revised Cardiac Risk Index, which has 4 components. I'm going to show you those on the next slide. The score basically comes out as whether it's low or less than 1% or elevated. If it's elevated, then you just need to find out the patient's functional capacity. And the way that we decide that is based on the METs of activity they can do. If they can do 4 METs of activity, which is, 2 bags of groceries up a staircase, or some heavy yard work or heavy cleaning, then we can take them to the operating room and they'll probably be fine. If they can't do 4 METs of activity and they are already a high risk, this is when we start talking about stress testing them before they go to the operating room. Okay, so this RCRI is a major decision point in whether you can just go to the operating room or whether you have to do some sort of functional assessment. So the way that you assess the cardiac risk is through these 4 things. So the first one is ischemic heart disease, and this is very broadly defined, right? So if I take my wife's nitrates every once in a while, then we're going to give me that point for ischemic heart disease. Or even if you find pathologic cues on the EKG. Never mind chest pain, exercise test, or a history of MI. Although I think current chest pain, honestly, unless it was stable angina, you'd probably worry that you needed to be up a section, right? And worrying about acute coronary syndrome. heart failure history, and this is either decreased ejection fraction on an echocardiogram or symptoms. Cerebrovascular disease, so patients who've had a past transient ischemic attack or a stroke are going to get a point here. Diabetes requiring insulin, so our diet-controlled diabetics or our people with an A1C of 6.7 who are on a touch of metformin, these people don't get this point. They get it only if they're on insulin. And then renal insufficiency, and this is measured by a creatinine over 2. So if you have more than two of those risk factors, 2 or more, then you're going to decide what to do next from a functional assessment. So like I mentioned, anything active is going to be addressed before elective surgery. It is important to know which surgeries are high risk, right? So anything where you're opening a blood vessel, much less the heart or the chest, is a high-risk surgery, right? And is puts someone at an increased risk that they're going to have one of these major events. The other thing is long procedures with blood loss or fluid shifts. So some of these big cancer operations where the abdomen is open for a long time, or sometimes they're unable to close completely at the beginning. The other takeaway point is that most patients with a good exercise capacity don't need a workup, right? So if I already know that you can carry your groceries up your 4 flights of stairs to your walk-up apartment, it almost doesn't matter what your RCRI is. You can go safely to surgery. And then low-risk surgeries, so things like cataracts, vasectomies, minor biopsies, rarely need any kind of workup regardless of the functional capacity. So I don't know about you guys, but I constantly get these little worksheets from ophthalmologists and dermatologists and people where they want me to clear someone for surgery, and the surgery is already very, very minor, right? And so those patients really don't need that. And so when you're on the boards, don't be thinking about what was on those worksheets, right? Because on there is like a chest x-ray, an EKG, a full panel of blood work, right? All of this stuff that's really not indicated. So perioperative beta blockers. So, this is something that can be a little bit complicated because of recent risk factor or demonstrations that if you start a beta blocker on the day of surgery, it increases the risk of these major cardiac events. However, we know that long term, it helps people. So the general plan now is that if the patient is on a beta blocker chronically, then they can continue to take it through their time to the operating room. If they have a lot of risk factors and maybe should be one on baseline, then it's reasonable to start before surgery, but you want to start several weeks before surgery. And we're never, ever, ever going to start it on the day of surgery. So labs. So, you're going to try to do as minimal testing as possible, especially when you're sitting for a major high-stakes exam. So hematocrit, only if they're over 65 or there's a risk of major blood loss. Otherwise, you don't need that. And we're not going to order a CBC unless it's cheaper than the hematocrit, right? So similar to everything else, we don't want to get like the MCV and all these random parts of the CBC if all we really need to know is the hemoglobin or hematocrit. For electrolytes, you don't need to check them unless there's a historical reason that they need it, like a history of hyponatremia or a medicine that puts them at risk. Similar to the creatinine. So creatinine is appropriate if they're over 50 going to surgery, or the surgery is a very big one where there's likely to have hypotension, or if they're on nephrotoxic drugs, either chronically or if we're going to use it in the operating room. The rest of these tests, glucose, liver function tests, PT, PTT, UA, all this stuff that we do all the time, not recommended unless there's actually clinical signs or symptoms. An EKG is not needed for low-risk surgery. It is indicated in patients who we know have coronary artery disease, arrhythmias, peripheral artery disease, any of this other structural heart disease to see if there's something going on, or if you're trying to figure out what their RCRI risk is and you're trying to find out what the Q waves are, but that means that you're already pretty sure that they're higher risk. It's not based on only an age. And then chest x-ray. So really, you can do a chest x-ray diagnostically in someone who's going to the operating room because they have a symptom, but unless they have a symptom, you really don't need to do it just as a screening test before they go into the operating room. PFTs are reasonable before lung volume reduction surgery. This comes up a lot with COPD. Right before we take out part of the lung, we want to know what's going to be left. It also is important for things like wedge resections when someone has lung cancer. Stents, okay, so dual antiplatelet therapy can be quite difficult during a surgery, so it's important to know the intervals at which it can be stopped. So if someone has balloon angioplasty, you can stop the dual antiplatelet therapy 2 weeks afterwards. If it's a bare metal stent, they need the dual antiplatelet therapy for at least 30 days to prevent in-stent thrombosis, which is an acute event where basically you can turn someone who got a stent for an end-STEMI into a STEMI with a complete occlusion very quickly. For a drug-eluting stent, they need it at least 3 months. If it's a procedure that's really needed, you can talk about it between 3 and 6 months, but we really prefer to wait 6 months before any elective procedure for a patient who got a drug-eluting stent. For the way that we stop these things, so aspirin generally can be continued throughout surgery unless it's a very major surgery with open blood vessels. Clopidogrel, we generally stop 5 to 7 days before surgery so that it can get out of the system. And then NSAIDs and COX-2 inhibitors all get stopped 1 to 3 days before the surgery because of bleeding risk. For anticoagulants, for a minor surgery, they can usually be continued. For a major surgery, the heparin will be out of the system in 4 to 6 hours, although many surgeons will take the patient to the OR with heparin running and then reverse it when they get there. Low molecular weight heparin is held 24 hours before. Novel anticoagulants are stopped 24 to 72 hours. And then warfarin, as you guys probably know, takes 5 days to get out of the system. So heparin bridging is another interesting thing that has changed a lot recently. We used to have people in the hospital after surgeries bridging their warfarin, bridging them with heparin back to warfarin for a pretty significant amount of time. But recently studies have come out for both patients who are getting warfarin for venous thromboembolism and people who are getting warfarin for chronic atrial fibrillation that bridging with heparin increases the risk of bleeding without actually changing the risk of venous thromboembolism, right? And so here you see the same thing where there's a bigger increase in major bleeding than there is a change in arterial embolization. So we actually no longer bridge with either heparin or low molecular weight heparin in patients who come in for procedures and need to come off their Coumadin or have their Coumadin reversed. So otherwise, the management for perioperative medicine is pretty straightforward. We really continue most of our cardiovascular medicines. Often we hold diuretics just because we know that anesthesiologists will have to give a lot of fluids in the operating room in the context of inducing anesthesia. And a lot of people will hold ACE inhibitors and ARBs on the way to the operating room just as a way of protecting the kidneys. Although if then that means the patient's going to show up for surgery with a blood pressure in the 200s over 110s, then we usually continue them. Estrogen, often people are very concerned about the risk of venous thrombosis in patients on estrogen, so we try to discontinue it several weeks before surgery or give them DVT prophylaxis to prevent that. And I think this depends a little bit on whether someone's getting it to prevent pregnancy versus getting it for hormone replacement therapy and maybe would be able to come off of it anyway. For diabetes agents, so we really prefer to manage someone's glucose in the operating room through insulin as opposed to oral hypoglycemics. So we usually stop them 24 to 72 hours before surgery. And then in the morning, we don't give the short-acting insulin, although you can still give the basal and half of the intermittent-acting insulin, right? Because if the basal insulin is supposed to just cover their metabolic needs, then they should still get it even if they aren't eating or anything else. Psychiatric meds can also cause a lot of problems in the operating room and interact with what they need to give for anesthesia. So you can see that most of these medicines can be stopped about 2 weeks before surgery, obviously not antipsychotics. And then often we taper some of these TCAs and lithium before surgery just because of all the complications as well. Neurologics mostly is continued. Remember that anti-Parkinson medicines have to be held the night before if the patient's going in for a deep brain stimulator, so that way they're able to make sure that it's placed properly. And then Alzheimer's drugs, because of their sort of limited utility in the short term anyway, since they're mostly chronic meds, they can be held before surgery. A 78-year-old man with a history of hypertension and diabetes falls and fractures his hip. He will require hip surgery. He could mow the lawn without any difficulties. His blood pressure is 150/90. His heart rate is 90. His chest is clear. His heart exam is normal, S1, S2, with no murmurs. He has no edema. His EKG shows normal sinus rhythm with left ventricular hypertrophy. His hemoglobin is 11, hematocrit 33, glucose 148. What would you recommend? Good, perfect. So he's going to go straight to surgery. I think the only tempting answer here is the nuclear medicine stress test. But remember, he would really need two things different in that STEM to need a nuclear medicine stress test. The first thing is they have to give you data that suggests that his RCRI is elevated, like that he's on insulin or that his creatinine is over 2 or he had a stroke in the past. And he would have to not be mowing the lawn before he came in for surgery. So we'll start with the preventative medicine, which this is my life as a primary care doctor. I spend about half of each of my visits talking through this, and this is also something that changes constantly. I'm always waiting for the new CDC guidelines to come out every year, because often I've told my patients, you're all done with vaccines, right? And then the new guidelines come out, and there's a new Zoster vaccine or something. So I will try to update you guys in all of these things and sort of simplify it for you so that it's easy to remember. The way that I like to think about preventative screening is based on the way that the way that things kill you. So first, number 1 is cardiovascular disease. Second, number 2 is cancer. And then third is infection, so things like pneumonia. And so I sort of run through like a checklist in my head of each of those things with each patient so that I won't forget. So I don't know if that framework will be helpful to you. So we'll start here. So important screening exams to know. So I mentioned cardiovascular risk factors, so blood pressure screening. So for cardiovascular risk, the age range we're going to be thinking about is from 40 years old to 75 years old. And you'll notice that in all of these things, blood pressure, cholesterol, and statin, 40 to 75, 40 to 75, right? And this starts at 40, but we do blood pressure ongoing. All right, so 40 to 75, what's going to change about blood pressure screening at 40? We're going to go from screening every 3 to 5 years to screening annually. Okay, so young people, every 3 to 5 years blood pressure. After 40, you get it yearly. Cholesterol, starting at age 40, that's when you start measuring it every 5 years. So I think clinically, a lot of us screen this test every year. That makes sense for someone who's being treated with a statin or another cholesterol medicine. But if they're normal risk, then you can just check it every 5 years. And this usually doesn't involve just measuring lipids. It also is measuring or calculating their cardiovascular risk along with this lipid measurement. The statin for primary prevention of cardiovascular disease. So between 40 and 75 for primary prevention, so this means they have no history of cardiovascular disease, you're going to calculate their ASCVD risk score. And depending on what it is, right, so if it's 7.5 or over, right, 20% or over, you're going to give them a statin based on that overall risk. And clinically, there's a great app for this, right? As a millennial, I can say that. I'm like barely a millennial. But you can do an app that'll actually tell you, and it'll tell you exactly whether to give them a moderate intensity statin, a high intensity statin, and even with the newest guidelines, what their LDL goal is, right? And so we used to have LDL targets, then we got rid of LDL targets. This past November, we got our LDL targets back, okay? So this is in primary prevention. We're gonna give them a statin if they have cardiovascular risk factors and their ASCVD event risk 7.5% or greater. If they have known cardiovascular disease, they're going to get a statin. If they have diabetes, they're going to get a statin, right? And then this question of whether they get a high or a low intensity is based on whether their risk is over 7.5%. All right, so that's cardiovascular. The next one is breast cancer. Okay, so the screening interval for cancers is generally 50 to 74 or 75 years, all right? And obviously these time ranges are gonna have exceptions for each of these categories, and I'll tell you about those. But we said cardiovascular disease is 40 to 75, Cancer is 50 to 75 or 74. So for breast cancer, we now do mammograms every other year between 50 and 75. Doing it every single year increases your need for biopsy, your false positive results, but actually doesn't improve your ability to detect cancers. Between 40 and 49 years, we individualize our recommendation here based on the patient preference, whether they have a first-degree relative that puts them at risk, or first-degree relative who has been affected, or if they have something else that puts them at high risk, something like chest radiation for Hodgkin disease or a BRCA mutation that would cause us to screen them earlier. For prostate cancer, we actually don't screen for prostate cancer right now anymore. This is because of the fact that we found that when we screen people, we actually are doing more harm than good. If we screen 1,000 men for 7 years for prostate cancer, we save 1 man from dying of prostate cancer. And in exchange for that death, we cause 30 men to become incontinent because of surgery, 20 to have perioperative impotence. We have 3 major cardiovascular events related to surgery, and then 1 patient who's going to die of the cardiovascular complications of surgery. So it's basically a 1-to-1 ratio, and right now we don't do PSA screening. I think that there's hope that as we can figure out the variable risk stratification for which men are highest risk for dying of prostate cancer and which men are most likely to have these cardiovascular risk or cardiovascular events, eventually we'll go back to screening, but right now we don't do it. The American College of Physicians still recommends shared decision-making, and this is what I do in my practice is I mention it, and if the person is interested, then we can talk about those risks, and they make the decision. For colorectal screening, we screen from 50 to 75. And the reason we stop at 75 here is because most of these screening tests, the benefit starts to decrease as the person's life expectancy goes down, right? So if I put someone through the risk of a colonoscopy, it's okay if I'm removing a bunch of polyps and they're going to live at least 10 years. But once they're going to live less than 10 years, the chance that one of those polyps would have become a problem for them starts going way down. And so at around 10 years of life expectancy is when we're going to stop all of these procedures. I think it's important to remember that because some patients have less than 10 years life expectancy at a much younger age, right? And so that's when we need to not screen them, right? So if someone has metastatic melanoma that's progressing through all the treatments, has already failed immunotherapy, that person is not going to benefit from a mammogram or a colonoscopy anymore. So with colorectal cancer, you can either do colonoscopy every 10 years, fecal occult blood test with 3 yearly DNA-based testing. So this is FIT testing, which is just 1 sample that can be done yearly to help decrease the risk. And these are actually pretty complicated, all of the different screening mechanisms. I think for the gen med portion of the test, it's going to be pretty straightforward, like one of these ones that we use more often. So I said I was going to mention the exceptions. So the exception for AAA screening from this 40 to 75-year-old age range is AAA screening. So to screen for AAAs, we really need a very specific population that's going to benefit from it. That's because the AAA surgery is so morbid, right? We were just talking about what's a high-risk procedure, and we said something that's long with risk of blood loss, where we open up blood vessels, right? So that's AAA surgery. So we're only going to screen the people who are most high risk. So that's male smokers between the ages of 65 and 75. Okay, so right now we don't screen women, we don't screen younger men, we don't screen older men. So then there are 2 exceptions to those age ranges for cancer screening. The first one is cervical cancer. So cervical cancer screening, we used to start it at first sexual activity. That's now been pushed back to 21. And then we're going to finish at 65 instead of 75. This is because by 65, most women that were going to develop cervical cancer will have developed cervical cancer, and they no longer need further screening as long as they seem to have cleared all the HPV infections that they've had in the past. So the way it works is between 21 and 30, the patient is often positive for HPV, but often is able to clear it on their own. So between 21 and 30, we test with Pap screening alone. Here it goes for 3 screening, Pap screening alone. We do not send an HPV test on a person between 21 and 30 unless they have ascus, right? So atypical cells of unclear significance, and we're trying to risk stratify them and decide what the next screening interval is going to be. After they're 30, though, many women will have cleared their HPV viruses. So you can start doing co-testing with both PAP and HPV, and this allows you to lengthen the time of screening. So you can do PAP plus HPV testing every 5 years between the ages of 30 and 65. You stop if the patient has had a hysterectomy for benign disease, and then you get to stop at 65, but only if the patient has been appropriately screened in the decade before that. So they need to have 3 consecutive negative PAPs, if they're doing just PAPs, or 2 co-tests every 5 years for the past 10 years, right, with 1 within the past 5. If that happens, then they can stop at 65, which most of my patients are very grateful for. CT screening for lung cancer is the other exception. So this is an interesting test where we're doing a yearly low-dose CT of the chest for people who are smokers, and that's defined as more than 30 pack years of smoking and either smoking now or quit within 15 years. They also need to be generally healthy enough that we would put them through whatever was needed to cure that cancer, right? So the life expectancy of more than 10 years is very important in this when the treatments are so very morbid. We're talking about like lobectomies and things like that. So when you pick the population right, though, you reduce the risk of lung cancer mortality by 20%. So what we do is, and then the high false positive rate is what I was talking about with you really have to pick your population carefully. I don't know if any of you guys are doing these screening tests. I have started them in my clinic, and I tell the patients that if we start doing this, we will find a bunch of little ditzels, little nodules that we're going to follow over time and that might eventually need biopsies. So for this, the age range is going to be 55 to 80. So instead of 50 to 75, we're going to push the whole thing back 5 years, 55 to 80. And I do think that it's benefited my patients. I actually had one of my favorite patients who had a screen positive back in November, and we diagnosed with her with a 2-centimeter small cell lung cancer, and she had it resected, and she's fine, and I'm so glad. So the immunization schedule, so this is sort of the basic immunization schedule that I think we're all aware of, which is that young people, we need to make sure they got their childhood immunizations, especially if they had parents who were declining for whatever reasons. We're going to catch them up. We're also going to give them the HPV vaccine, which is now approved for men as well between the ages of 11 and 26. Everyone gets a flu shot. Everyone needs a tetanus shot every 10 years with a Tdap replacing it once. This is especially important with the active pertussis epidemic that's going on. I know we're hearing about it all the time in Houston. And then, over 60, things start to get more complicated. So in the past, we were giving the zoster vaccine, just 1 dose over the age of 60. But now we're sort of shifting to this recombinant zoster vaccine, which is a new thing that's 2 doses. And I'm going to talk a little bit more about how that's changed the age range for the shingles vaccine. So first, we'll talk about pneumococcal vaccines. So everyone over 65 needs a pneumonia shot, right? Anyone younger than 65 needs to have careful decision about which one they get. So there are 2 vaccines, the PPSV23 and the PCV13, okay? So if you're 65 years of age or older and an average risk person, then you're going to get the PCV13, and then 1 year later, you get the PPSV23, and then you're done, okay? Now, the PPSV23 and the PCV13 each have specific risk factors that would cause you to give them earlier, all right? So for the PPSV23, it's anyone with chronic heart, lung, liver disease, diabetes, alcoholism, or smokers, okay? So what this means is almost all of my patients get the PPSV23 before they turn 65, right? And then at 65, I give them this PCV13, and then 1 year later, the PPSV23, okay? So look at this list. These are all the people that get PPSV23. For the PCV13, the things that cause you to give it earlier are different and more specific, okay? So immunocompromising conditions, especially asplenia, right? So remember that pneumococcus is an encapsulated organism, and so if you're going to get a splenectomy, then you need to be vaccinated against pneumococcus, or a CSF leak or a cochlear implant, okay? So PPSV23 is heart, lung, kidney disease, smoker, alcohol, right? PCV is asplenia, immunocompromised, cochlear implant, CSF leak, right? So the PCV is much more specific, right? And in these cases, you're going to be doing them 8 weeks apart, with the second one 5 years later. And I think that these guidelines are changing a lot more, but it's important to keep these in mind for these more complicated patients. Okay, so remember just a few things. I think we all know in pregnancy, you can't give attenuated live vaccines, right? And so the live attenuated shingles vaccine you can't get. The new one, the recombinant shingles vaccine, you can. But we're not going to give MMR, oral polio, yellow fever, typhoid, varicella, or nasal influenza to any of our pregnant women. In HIV, we can probably give them all other than smallpox, which we don't give anyway. But if they're very severely immunocompromised with a CD4 count less than 200, then we often avoid MMR and the VZV live attenuated because of the risk of reactivation. And then, so this recombinant zoster vaccine is a new one that is superior to the live attenuated vaccine. And so because it works so much better and actually decreases the risk of getting shingles by 90%, we're now giving it at the age of 50. The problem is very few insurance companies are covering it at the age of 50. So that's been something that's an ongoing struggle. And when you have a new vaccine that everyone over the age of 50 needs, in the entire city of Houston, we never have it in stock in our clinic. None of my patients can find places where they can get it. So, it's been a little bit difficult to start using those guidelines regularly, but the recombinant zoster vaccine can be given after the age of 50 and benefits a lot of people. So just to summarize a little bit more about the vaccinations for patients at risk. So if you're asplenic or you're removing someone's spleen, let's say they have idiopathic thrombocytopenic purpura, you've got a planned splenectomy, they come to you for primary care. You're going to give them the HIV, the pneumococcal vaccine, remember the PCV13, and then 8 weeks later the PPV23 and the meningococcal vaccine. For chronic liver disease, you're going to give them the hepatitis A and B vaccine to avoid them getting them both later and then going into acute liver failure. This is also the same list that you're going to give to men who have sex with men based on their risk factors. Healthcare workers get hepatitis B, influenza, MMR, and Tdap. IV drug use is hepatitis A and B and Tdap. And then lung disease, pneumococcal, and influenza, right? Which I think that this probably makes sense given that everyone who's sick gets pneumococcal vaccine younger, and everyone gets influenza every year. I think the other thing to keep in mind is that the guidelines recently changed for Tdap so that you give it to a pregnant woman with every single pregnancy. This is because of the problem, the resurgence of whooping cough among small children and babies, and so they're just trying to boost these women every single time they're pregnant. Highly uncomfortable, as you guys can imagine. Okay, so a woman makes an appointment for a physical exam when she turns 65. She has not seen a physician for 12 years, and that visit was for a skin rash. She has not had a regular doctor because she lacked insurance. In addition to mammography, appropriate preventive care should include, pick your answer. Good, exactly. So she definitely needs an FOBT, right, since she's over 50. She definitely does not need a CBC, since CBCs, especially on multiple choice questions in this situation, is not going to be the answer, right? We're going to have like a hemoglobin that we ask for or a white blood cell count that we ask for. And then the question is Pap smear. So I just told you that Pap smears are an exception to the rule that we screen from 21 to 65, unlike other cancers that are 40 to 75. So 65, she should be done. But the problem is she hasn't seen a doctor in 12 years, right? And so in that context, she hasn't been appropriately screened in the past 10 years. She's going to need a Pap smear. And then it looks like a lot of you guys picked CBC. I think this is one place where the guidelines and what we do clinically is quite different. All right, audience response 28. Which patient meets guideline criteria for AAA screening? Perfect. So a 66-year-old man with a 60-pack year history of smoking quit 10 years ago. So for the AAA screening, remember, it's any man. This is our exception to the cardiovascular rule, which is usually 40 to 75. So this guy is between 65 and 75, so he needs AAA screening as a past smoker. And it's actually any amount of smoking, more than I think it's like 100 packs of cigarettes over a lifetime. So he clearly needs it. I think, the question is, how could we change the STEM where we would have to screen almost all of these people? Let's see. So if it said that we need to do a CT lung cancer screening, then it would be the bottom 4, right? If we said which of these people needs the shingles vaccine, then we'd get all 5, right? Let's see. So then, next question. In November, a 34-year-old woman presents for primary care. She reports she's 24 weeks pregnant. She was last seen by a medical provider 13 years ago. She reports no history of chickenpox. She received all regular immunizations growing up, with her last immunizations received prior to college 16 years ago. Which immunizations would you recommend? Good. So Tdap, because as I mentioned, we're going to give Tdap to every woman on every pregnancy, no matter how frequently she's coming in with a pregnancy, and every person gets an influenza shot every year. So here, varicella is a live attenuated vaccine, and so we're not going to give it to a pregnant woman. Let's see. Yes. And I think that this is really important. As an internist, I don't really see that many pregnant women, but it's important to remember that 50% of pregnancies are unplanned. And so a lot of people who come into me, I was just talking to a friend actually, and she's like trying to talk about her acne and how she wants doxycycline for her acne, but then her period was a week late. And I was like, you probably should check that before we start talking about anything else. So a lot of these pregnancies are being managed by us. And if we had talked to this woman before her pregnancy, we could have given her varicella to prevent any risk for the baby. All right, the last one for this section. A 61-year-old man presents to clinic to establish primary care. He is healthy and has no significant medical problems. He has not seen a physician since he had an annual at 50 years of age. In addition to seasonal flu, which immunizations would you recommend for him? Okay. So exactly, so Tdap and varicella zoster, right? Tdap because it's been more than 10 years since his last tetanus shot and we don't have any record of a pertussis vaccine. And then varicella zoster because he's over age 50. Let's see, it looks like the next top one was E, which is Tdap, varicella zoster, and pneumonia. So that would definitely be true if it said anything about smoking or alcohol or chronic obstructive pulmonary disease, renal disease, cardiac disease. I mean, it's very easy for a 61-year-old to qualify for the pneumonia shot, but we just don't have that in this STEM. The other way he could qualify for it is to be 4 years older and be 65. So this would be the right answer if he was 65 years old. Let's see. Just remembering the Tdap. I think that this covers all of it. All right, a 19-year-old woman is evaluated in the emergency room for severe headache and altered consciousness. She has a lumbar puncture and is found to have meningococcal meningitis. Her mental status deteriorates and she requires intubation for airway protection. Who should receive meningococcal prophylaxis? Yeah, so it's tricky because now we're talking about infection control, which is a little bit off topic, but I think it's important just to cover it a little bit. So it's mostly based on airway secretions, right? So it's the anesthesiologist who intubated the patient. The other people would not necessarily need any prophylaxis against meningitis. Number 32, this is another infection control question. An influenza epidemic strikes a nursing home at which you are the medical director. The patients received the influenza vaccine yesterday, but cases began appearing 5 days ago. You now have 11 confirmed cases of influenza A. What do you recommend? Good. So the answer is D. So for these nursing home outbreaks of influenza in the context of not having access to the vaccine in adequate time, it's really important to start all the residents on oseltamivir to prevent one of these disastrous epidemics with spread. All right, quality and safety. So this is one of these things that if we don't know how to do it, other people always do it for us. And it always turns into more pop-up windows in my electronic medical record that I have to click through, So I think it's important for us to learn about these things, although, there's only very specific things that can be asked of us on standardized tests. So types of quality measures, all right? So there's 3 different types of measures, and I think when we talk about quality, we usually are sort of thinking about just STALT, but for these things, it needs to be very, very specific. So a process measurement asks not whether the A1C is well controlled, but are we even measuring the A1C regularly, right? So not are we reducing flu, are we giving more flu shots, right? The outcome measure is the one about how we're actually doing, right? So what's the A1C? What's the blood pressure control? What's the rate of flu among our patients? And then balance measures look for unintended consequences. So when we prioritize making sure we're giving a lot of flu shots, how does that affect our A1C and our blood pressure control and our discussion of advanced directives, because it's taking time out of the visit, right? So it looks for unintended consequences. I think all of us have seen these consequences that happen in real life where they ask us to do something and then we don't have time to do something else. And that's why these balance measures can be really important in a project to make sure that things are, all aspects of the problem are being addressed. So PDSA cycles is the most common approach to QI, and it's the way that the Institute for Healthcare Improvement teaches quality improvement. The idea is that you have a specific outcome, and then you do this cycle to try to improve it, and you do multiple cycles. Instead of trying to be perfect with each intervention, you try to do little interventions and then measure it quickly. So the cycles plan, do, study, act. So the idea is you plan your intervention, then you implement it, you get a measurement out, you try to make it a measurement that you can see quickly. It's called a lead indicator, something that'll tell you that your A1Cs are gonna look good even before you see the A1Cs drop, and then you act. And so you either make it sustainable by hardwiring it into the system. So this is things like putting it in the electronic medical record, creating a worksheet and asking all your medical assistants to give it out, hiring something to do whatever intervention you've decided. Or look at it and be like, ooh, totally didn't work, right? And then you're gonna change and get rid of it and try a new intervention. So PDSA cycles. There's a bunch of other models for improvement in patient safety, okay? So one of them is a root cause analysis. And so this is usually a multidisciplinary attempt. We all get together and we talk about an adverse event or a problem or a near miss, and we talk through all of the things that could have caused it. And there's a bunch of different ways you can do a root cause analysis. Sometimes we do a fishbone diagram, which you guys may have seen, where it's, what are the structural causes of this, and what were the personnel causes, and what were the electronic medical record problems, and what are the administrative causes, and we brainstorm. The other thing is something called the 5 whys, where you guys are like, well, you gave too much insulin to the patient. Why? And I'll be like, because I was going too quickly. Why were you moving too quickly? Because I had 24 patients to see. Why did you have 24 patients to see? Like that. So you can try to figure out what the underlying cause is. And a lot of times you'll eventually get to something like, I gave too much opioid because there wasn't a pharmacist on staff that was double checking my problem. And you're trying to get away from this name, blame, shame culture where you have one person who's held responsible and towards something where you're trying to create a safe structure where even if someone makes a mistake, it's sort of like impossible for them to fail. So that's the idea behind a root cause analysis. So 6 Sigma is another thing. You guys have probably heard of 6 Sigma black belts. I don't know if you have these people walking around your hospital or like yellow belts and green belts. It seems really cool. I probably should learn more about it and get one. But the basic idea is that you're trying to reduce defects. And you can define defects anywhere you want, in any way you want in the Six Sigma methodology. It might be a patient that waited too long for a CT scan. It might be a patient who spent more than $100,000 in their cost or variation, right? The one person who died of influenza, and you're trying to make them more and more unlikely. And sigma means the number of standard deviations away from average. So 6 sigma is trying to make these defects 6 standard deviations away from the median, right? So I think it's like 1 per million or something. And you're trying to just focus on these defects and trying to get rid of them. Lean technique is another thing. This is the Toyota model that a lot of you guys may have heard of. They wrote a lot of books about it. And the idea is that you engage the frontline staff, you ask the people who do the work what is wasteful in what they do, and then you try to get rid of the waste, right? So I go to my residents and I'm like, residents, why are none of the patients getting DVT prophylaxis, right? And I talk to them about it to try to figure out what's wrong, and I find out that the order set is hidden, or there's too many pop-up blocks, or it's not even in the admission order set. And so this is a way to try to eliminate waste, as opposed to, a little different from something like a root cause analysis where all the leaders sit around and pontificate about what we think is wrong. And then adjust culture. So this is similar to what I was talking about before. So, this is a situation where if I almost give too much insulin to a patient, I'm like, hey, I almost gave too much insulin to a patient. And they're like, wow, thank you for telling us that, as opposed to being like, you bad doctor, you need to figure this out, So it's an environment where reporting the unintentional error is rewarded, right? But not reporting it is a bad thing. So it's getting rid of this individual responsibility and trying to develop an idea of collective responsibility for errors. And so the way this can show up on a test is through things like where they ask you, there's an error, should someone, and one of the answer questions is fire the person who did it, right? And that's usually not the answer, because if the reason that I gave too much insulin is because the order set is confusing and I click the wrong button, you can fire me all you want. Someone else is going to order the wrong dose of insulin next time, right? And it gives you a false sense of security that you've dealt with the problem when you actually haven't done one of these other things to sort of look into the deeper reasons why. Okay, so now that's it for QI. Toxicology. So this one is kind of fun, I think. So there's general principles, right? So we're always going to protect the airway. You can always give these certain things to try to make sure someone gets better, almost without any data, right? So D50, make sure that they're not hypoglycemic. Naloxone, make sure that it's not an opiate overdose. I think with the opiate epidemic, once again, this is something we want to remember for our upcoming tests. And then thiamine, right? So you want to make sure that if someone is coming in encephalopathic because of alcohol, that you give them thiamine before you push that D50. You can also always send the basic metabolic panel to see if you've got some sort of anion gap, to see what the creatinine is, an ABG to check for carboxyhemoglobin levels and other things that can mess with the partial pressure of oxygen and carbon dioxide, and then a serum toxicology screen. You're going to calculate both the anion and the osmolar gaps, and you're going to compare them. So remember that the anion gap is looking for unmeasured, basically acid in the blood, and we'll talk a little bit about what can cause that, whereas osmolar gaps are basically any active osmol that's not measured normally in the sodium and the basic electrolytes that we usually check. You can measure the serum acetaminophen and salicylate levels, and then start to think about gastric decontamination, either lavage or charcoal. Remember, there's a few exceptions to the lavage and charcoal rule. So first of all, there's a bunch of things that charcoal doesn't help for. It doesn't help for caustic materials like acids. It doesn't help cyanide absorption. It doesn't change the way, electrolytes. If I take a bunch of my potassium pills, it won't matter if you give me charcoal. The alcohols can still absorb, and that's not just ethanol, it's ethylene glycol, methanol, hydrocarbons, and then heavy metals. All of these things can be absorbed despite charcoal. And then, then when we have this anion gap metabolic acidosis, there's a way to remember what can be the causes of it, right? And so this is something called mud piles, is the mnemonic we often talk about. So methanol, uremia, ketones or diabetic ketoacidosis, paraaldehyde, isoniazid or iron, lactate, which can be from metformin, HIV meds, sepsis, mesenteric ischemia, ethanol or ethylene glycol, salicylates, and toluene. So we're going to review a few of these toxins in a little bit more detail to make sure that we know how to manage them, especially because they can kind of have overlapping presentations, and it's important to not get them mixed up. So anticholinergics first. So this is another mnemonic that we can all remember, right? So red as a beet because of the cutaneous vasodilation, dry as a bone because of the anhidrosis, hot as a hair, so their blood pressure can go up, or their temperature can go up quite a bit. They get severe mydriasis, and so they have visual disturbances, blind as a bat. Mad as a hatter, this is the delirium, the confusion, the hallucinations. Full as a flask because of the urinary retention, right? And the antidote here is physostigmine, which is basically going to reverse all of that and make a patient feel better. There's many things that this can be confused with. One of them is TCA overdose, which we're going to talk about next. The other thing is serotonin syndrome, and I think the way that you can discriminate serotonin syndrome from anticholinergic overdose has to do with this dry as a bone. So serotonin syndrome is going to cause diffuse sweating, you're going to have diarrhea, but you'll also still have some of these other things, hyperthermia, mydriasis, all of that. But that's the way that you can tell the difference, other than obviously exposure. The other thing that can make someone super hyperthermic is neuroleptic malignant syndrome, right? But there, instead of having tremors or anything else, the person is going to be super rigid, right? And so the rigidity is what can help you identify neuroleptic malignant syndrome compared to these other things. And then the final thing that can increase the temperature from a toxic perspective is malignant hypertension. Now, this is genetic. This is going to be more of a hyperthermia without other problems, and it's going to always be in the context of anesthesia. So to just talk a little bit more about TCA overdose, because it is very common in the context of hospitalization from intentional overdose. It causes cardiovascular toxicity, CNS effects, and a lot of these anticholinergic effects that you guys saw on the previous slide. The way that you deal with it is with the charcoal and the lavage, especially within 2 hours. But the antidote is sodium bicarbonate, and that's important because in the last slide I told you that you treat anticholinergic overdose with physostigmine, and here it's really dangerous to give physostigmine. So it's important to look for these TCAs before you give that medicine. The physostigmine and procainamide can cause severe arrhythmias or even asystole in these patients. You can treat seizures with benzodiazepines, and remember that drug levels don't always tell you the whole story as far as whether the levels are going up or going down. Depending on the time of the dose, you could still have a lot of toxicity without abnormal drug levels. Okay, so then acetaminophen is another common poisoning from intentional or unintentional overdose. The thing to remember about acetaminophen toxicity is it sort of has a delayed course, and it goes over 4 different stages. So the first stage is from the first 24 hours, and it's usually asymptomatic or has mild flu symptoms, right? So achiness, malaise, nausea, and vomiting. But then between 24 and 48 hours, it moves to stage 2, where the liver enzymes start to rise. And this is the first hint that the patient is in danger of severe fulminant liver failure. Stage 3, between 49 to 96 hours, is when the symptoms really peak. And this is when the patient comes in and they're jaundiced and they're coagulopathic and their LFTs are massively elevated, and this is when death can occur. And so the patient really requires maximal support to make it through this period. But if you can get them through those first 96 hours, those first 4 days, they can recover their liver function quite phenomenally well. So you're really trying to support them through this. We talked about acetaminophen in the context of Coumadin before. I think in this situation, remember that for an overdose that causes liver toxicity, it takes about 7.5 grams or even more than 10 grams for a healthy adult to get acute liver damage. But if the patient already has liver disease, hepatitis C, non-alcoholic fatty liver disease, chronic alcohol use, things like that, then it can take a much lower dose to cause an acetaminophen overdose. The management: in the first 2 hours, gastric emptying, right? After that, usually the stomach is no longer full of the material, so you can give activated charcoal up to 4 hours. And after that, really, the only thing that's going to help is N-acetylcysteine or NAC. You can give 17 doses. You can give it either PO or IV, and it's really good to get it in as early as possible within 8 to 16 hours of ingestion. You can get acetaminophen levels, and we usually do, and we put them on that nomogram to decide whether it's toxic enough or not based on the amount of time it was since the patient came in. But clinically, when someone comes in with elevated LFTs and a history of acetaminophen dose, we just give the N-acetylcysteine and ask questions later, right? Because this is such a serious disease, and N-acetylcysteine doesn't really have any side effects other than that it smells terrible and tastes terrible, which is why we usually do the IV. Okay, so nitrites are something that is increasing, unfortunately, in popularity. These are poppers. I don't know if you guys have seen these things, but patients can inhale them, and they basically decrease the smooth muscle tone throughout their body. So they become tachypnic, tachycardic. They can get a headache. Their blood pressures often drop. But most importantly, they can develop methemoglobinemia, right? So you probably remember methemoglobin is a molecule that basically, when the hemoglobin changes this way, it can't unload the oxygen. And so it travels around and it becomes this like blue color. I'll never forget, actually, as a med student, an ABG I did, the patient had methemoglobinemia, and I saw this like purple grayish blood come out of the patient, and I was so creeped out. I had no idea what was going on. And then my resident actually yelled at me that I had done a venous blood draw, and I was like, no, it was pulsatile. I know that it was arterial, and the patient had methemoglobinemia. So you know, when it's cycling through, so you'll have a higher PO2, and the oxygen saturation will be stuck at like 88 to 92%. Let's see. And the way that you treat that is with methylene blue. The features of MDMA, ecstasy intoxication, so it's been around for about 20 years now. This is something that lasts for about a night. It causes euphoria, increased sexual arousal. People can get bruxism, which is tooth grinding, and tachycardia. The problem is that they drink a lot of water, and so it can cause very severe hyponatremia. And that's what these patients also often come in with, is hyponatremia. They can have seizures and all sorts of very serious side effects like that. However, it's not addictive in the same way that methamphetamines are. Okay, so methamphetamines have a similar problem where you get hypertensive, tachycardic, sweaty, but they have a lot more agitation and psychosis, and they're much more addictive. So they have more physical manifestations. People get meth mouth from this chronic bruxism and the lack of saliva, dental cracking, decay, cavities, and then skin excoriations where they, are picking at their skin in the context of chronic abuse. So this is meth mouth. So you can see how there's eating away at the gum line from the chronic bruxism, and there's parts back here where the teeth are being basically worn away from the grinding. So it's important to remember all of these antidotes, right? And you basically just have to memorize them. A lot of them, some are easier to remember than others, right? So we talked about acetaminophen and N-acetylcysteine. Narcotics, I think we all know to give naloxone. Benzodiazepines, flumazenil. It's nice because it has a Z in it, just like there's lots of Z's in benzodiazepines. Nitrates, I just talked about those poppers that you can give methylene blue for. Sometimes it's easy for me to remember because the poppers, lots of times those bottles are really bright colors, like bright blue, so I can remember methylene blue. Iron, deferoxamine, right? Methanol, famipazole, incredibly expensive, but can make a big difference if you have a patient who has a big osmolar gap, or renal failure, right? Who comes in with methanol toxicity, the organophosphates, and then cyanide, nitrates, and sodium thiosulfate. So we are going to do a few questions here. The first one, the agent of choice for treatment of the arrhythmia associated with TCA overdose is which of the following? Good, so the sodium bicarbonate, exactly. So we're remembering that TCAs can cause the anticholinergic side effects, but we're not going to treat with physostigmine like other anticholinergics, right? Procainamide and amiodarone are both things that we would use if the patient developed an arrhythmia, and then naloxone is our antidote to opioid overdose. A 20-year-old woman presents to the emergency department tearful and agitated. She reports she took a bottle of extra-strength acetaminophen 2 hours ago in a suicide attempt. Her physical exam is normal. Her hemoglobin is 13, hematocrit is 39, white count is 9,000. Acetaminophen level is 280, toxic at 4 hours. What would be the most appropriate management? Perfect. So activated charcoal and N-acetylcysteine, right? So since she is less than 4 hours, but more than 2 hours, if it was less than 2 hours, we would give the gastric lavage. We're basically never going to give activated charcoal alone, right? Because I said we give N-acetylcysteine almost all the time, but especially in the context where she's already got a toxic level. N-acetylcysteine alone we would do if it was after 4 hours from her overdose time. And the deferoxamine is a treatment for hemochromatosis, iron overload, aluminum overload, but it's not related to acetaminophen overdose. All right, a 29-year-old man is brought into the emergency department by friends. The patient was at a party with his friends when he became confused and then unresponsive. On exam, his blood pressure is 60/30, his heart rate is 140, his temperature is 96 degrees, oxygen saturation 88%, and extremities with marked cyanosis. He has cyanosis of his lips. His hemoglobin is 14, hematocrit 42, white count 1,000. His pH is 7.32, PO2 86, PCO2 44. His sodium is 136, potassium 4, chloride 105, bicarb 20. The patient is placed on 100% oxygen by face mask without improvement in his cyanosis. What therapy should he receive? Good. I'm so happy with that 96%. So methylene blue, right? Because poppers are bright blue. This is a person with nitrate overdose. And it's going to, the problem is the thing that really gives it away here is we have cyanosis that doesn't improve when we give 100% FiO2. And he continues to have an oxygen saturation of 88%, even though the partial pressure of oxygen in his blood is 86 millimeters of mercury. So he really should be able to get more oxygen loaded onto that hemoglobin, but he can't because it's methemoglobin. Okay. A 45-year-old male patient calls you on Sunday afternoon. He's been having nausea, vomiting, and diarrhea today. He also has had a headache and mild dyspnea. These symptoms actually improved when he was shoveling snow earlier in the day, but they've now returned. He reports his wife is sick in bed with the same flu-like syndrome. What do you recommend? Exactly. So, this is carbon monoxide poisoning, which I haven't talked about explicitly, but it's very, very important to remember it because of this, because it's so high risk, because it presents with such sort of weird symptoms. But, if someone starts talking about garages and power outages and it being winter and shoveling snow and getting better, right? Then this is the question about carbon monoxide poisoning. Remember also that carbon monoxide has a higher affinity for fetal hemoglobin than it even does for adult hemoglobin. So for a pregnant woman, often the fetus will, have decreased motion and even the intrauterine death before the mother even necessarily has symptoms. So it's a very, very important thing to keep in mind. All right, ear, nose, and throat. So we're going to start with a question this time. An obese 36-year-old woman presents for evaluation of headaches. She's had increasing problems with headaches over the past 6 months. She has had no visual symptoms. She has had occasional nausea, but no focal neurologic symptoms. The headaches keep her home from work. Her blood pressure is 120/70. Her heart rate is 80. Her skin shows no lesions. Her fundi, I'll show you in a minute. Her neurologic exam is normal, and she's on calcium carbonate, OCPs, and fluoxetine. That's her ophthalmologic exam. What is the most likely diagnosis? So it's so tricky, right? So the answer is headache from oral contraceptives because here you see her optic disc and there's nice sharp borders, right? So for pseudotumor cerebri, remember that she's going to have elevated intracranial pressure because it's a pseudotumor. It looks like a tumor, right? So it's going to look similar to glioblastoma, which will also have papilledema, tuberous sclerosis, and then Prader-Willi syndrome. Remember that this is not something that we often see in adults. It's usually diagnosed in children. It is something that is, when it's passed down from the mom, then the patient gets obesity and Prader-Willi syndrome. If it comes from the dad, they get Angelman syndrome. But it's mainly, obesity, too much of an appetite, that sort of thing. So the answer here is headache from oral contraceptives. Just remember that even though we talk about pseudotumor cerebri all the time, it's actually very rare. 3.3 out of 100,000 women compared to just OCP-associated headache, 600 out of 100,000. So OCPs do have side effects, headaches, hypertension, all of that sort of things, besides just acne sometimes and weight gain. So pseudotumor cerebri is idiopathic intracranial hypertension, but there is actual elevated blood pressure in the brain. 90% of the patients are women and they are obese. They have headaches that follow the normal pattern of what we see in a brain tumor, so it's worse in the morning. And they even have visual disturbances, both the scotomas that we see in migraine patients and also the blurry vision. They can have pulsatile tinnitus, which I think is a very concerning symptom. Usually it means some sort of AV malformation, especially if it's unilateral, but it can be seen in pseudotumor cerebri. But they will have papilledema. The other thing that they can have similar to other patients with increased intracranial pressure is the sixth nerve palsy, because remember, as the pressure increases and the brain starts pushing down, that sixth cranial nerve can get affected. So the way to diagnose it is with a lumbar puncture. You'll find that the CSF is normal, but that the opening pressure is enormously elevated, over 250 millimeters of water, and you can treat it with acetazolamide. So there's papilledema, so you can see what it looks like. There's even some hemorrhage. There's blurring of the optic disc. It's quite striking. So ophthalmologic emergencies. So what do we need an emergent consultation for? I think some of them are very obvious, like an alkali burn. No one's going to come in. You hear that someone had an acid or a basic material in their eye, and we're going to just send them home from clinic. You're going to get a lot of water irrigation and get them in to see an eye doctor. Central retinal arterial occlusion is very important. Patient will come in and all of a sudden they'll have painless unilateral blindness. And I would say the biggest problem here is that lots of times people don't even realize that it's so dangerous. I had a patient who would have this come and go for a little while before they decided to come in. When you look at the back of their eye, you'll see this cherry red spot. And the reason is because all of the other blood vessels sort of decrease in diameter because there's so much less blood flow coming from the central retinal artery. And so you'll see the cherry red spot there. And the way you treat that is with this ocular massage, Trendelenburg. You have them breathe into a paper sac and you get them in to see a ophthalmologist right away. The other thing to think about is angle closure glaucoma. This is something that we can trigger in our patients. They already have glaucoma and then we give them steroids, but it's usually a patient who comes in with a red eye that's painful. People can come in with a red eye for all sorts of benign reasons. People come in with allergic conjunctivitis. People come in with, bacterial conjunctivitis. But if it's red and painful, or red with a change in vision, then it's an emergency, okay? So angle closure glaucoma, classically the eyeball is gonna be kind of hard. It's gonna have this fixed pupil that's not gonna not gonna respond to light. And then it's gonna have a ciliary flush. So since the pressure is really high in that anterior chamber of the eye, you'll see that there's redness just around, like really focused on the center, just around the pupil of the eye. All right, penetrating injury, I think we would all know to send to an eye doctor. Endophthalmitis, this can be bacterial or fungal. And the way that it's really going to present is with this hypopyon, right? So remember that this is like a layer of pus in the anterior chamber that lets you know that they've got this infection there. Retinal detachment, so these people have photopsia. They'll describe like a shade or a curtain coming down over their eye, or black dots. This is something that can be improved if you can get them into the hospital quickly. And then orbital cellulitis. So it's one thing for someone to have, a little eyelid infection or to have a cellulitis other parts of their eye, but as soon as it starts causing diplopia or pain with eye movement, then it becomes an emergency and you have to move it forward. The other thing to think about with a red eye is make sure that you're considering whether someone uses contacts or whether they've had something that could cause keratitis, right? So keratitis can be due to HSV. There are fungal causes of it. You can even get gram-negative rods that can cause conjunctivitis or keratitis. And so all of those things, if someone uses contacts, even if they don't have blurry vision, even if they don't have pain, they usually need to see an eye doctor urgently. All right, so pharyngitis, there's a ton of things that can cause pharyngitis. I see it in clinic all the time. I think the one that patients usually come in asking for is a strep test. I think the thing to remember is that, a strep test has a very poor sensitivity and specificity, and actually guidelines don't suggest that we use it that much, even though we use it a lot. So these 4 clinical features, tonsillar exudates, absence of cough, tender adenopathy, and fever are called the center criteria. And if a patient has 4 of these, all 4 of them, then we're supposed to just empirically treat them for group A strep pharyngitis. If it's 2 or 3, then people talk about sending a culture. And then if it's 1 or 2 and it seems low likelihood, then you don't treat them at all or send a culture. So I think it's important on the boards that we remember that rapid strep test is not very effective. Mononucleosis, so it can cause the tonsillar exudates. It can look a lot like group A strep, but people are going to have splenomegaly. They're going to have petechiae on their hard palate, and they're going to have much longer lasting fatigue. That's going to be way, way different than the strep. They're also going to have lower fevers than the group A strep patients. Chlamydia pneumonia can cause a pharyngitis. It usually is associated with hoarseness. And then mycoplasma can cause this pharyngitis that's associated with erythema multiforme, right? So this rash all over your body and problems, bullous laryngitis. Viral pharyngitis is very common. And the way that you're going to know that it's viral is that it's going to be, I think it's more than 2 mucosal surfaces affected, right? So if it's my throat and my nose or my throat and my GI tract, then it's most likely due to a virus because it's very rare for a bacteria to get in all these different places. And then, of course, acute HIV. So HIV you're going to know because of the lymphadenopathy primarily. You can have a rash, you can have ulcers in addition, but the tonsillar exudates can be very similar to what you see in group A strep or mono. So chronic cough, another ENT complaint we see a lot. I was always taught that these top 3 were the most common, and they still are the most common, except for now, instead of causing it postnasal drip, we call it upper airway cough syndrome, but it's still the same thing, right? The residents actually make fun of me in clinic because I put all of my patients on nasal fluticasone. I feel like it's like a human thing that we just need a little less inflammation up there. GERD, so gastroesophageal reflux disease. The way you're going to know that it's probably GERD, the patient's going to wake up with a sour taste in their mouth. They're going to notice that it's worse when they lay down at night. Now that can be tricky because upper airway cough syndrome also can get worse when they lay down at night, but usually it'll have seasonal variation and you'll see the cobblestoning in the back of their throat. For asthma, they usually have a history of asthma as a child, or they'll tell you that they're the kind of person that every time they get a cold, they cough for a few months, right? And so you'll be able to tell, even if they aren't wheezing, that they need some sort of inhaler to help decrease their cough. There's a bunch of other things, right? So eosinophilic bronchitis, medication. So people take inhalers where the carriers, they can get an allergic reaction to it and it causes a cough. ACE inhibitors, obviously, very important, but I'm always surprised at myself when a patient comes in on their second visit for cough and I notice their ACE inhibitor, so don't let it happen on your test. And then finally, malignancy. All right, so malignancy is sort of the dread complication, but in the context of seeing tons of patients with chronic cough, it often will fall to the back of our list. What I've heard from a guideline perspective is if you've had the cough, if it moves from acute to subacute, so if it's more than 3 to 6 weeks long, that's when you need a chest x-ray to rule out malignancy and just make sure that the person does not have lung cancer. Acute sinusitis, so we diagnose this clinically as opposed to with a sinus CT. You really only need a sinus CT if they've had recurrent refractory disease, you've already sent them to an ENT who's done an endoscopy, and you're kind of trying to see if there's any polyps or anything like that that's blocking the nasal passages. Remember that 90% of acute sinusitis is viral. And so, if it shows up on your test, it's most likely viral because they're trying to make sure that you're going to preserve antibiotics. But there are some times that we use antibiotics for sinusitis. One is if it's more than 10 days of symptoms. The other one is if it's severe. So this means fevers over 102, purulent nasal discharge, facial pain lasting more than 3 to 4 days, and usually it's one side worse than the other. So it's very rare to get bacterial sinusitis equal on both sides of the face. The other thing is worsening symptoms, so this double sickening, which I see in my kids all the time, where they'll get a virus, they'll have a runny nose for a week or so, and then they're getting better, and then all of a sudden they wake up at 2 a.m. crying because their ear hurts, right? So this is called double thickening, or double sickening, not double thickening. Although I was thinking about how there's thickening of the mucosal passages, right? And so they can't drain very well. And so my kid wakes up with otitis media, or our patient comes in with acute bacterial sinusitis because of the lack of drainage that was caused by the viral infection. Okay, so acute sinusitis, if you do decide, based on those previous criteria, you're going to treat it, obviously everyone can get decongestants and saline irrigation, but the treatment is amoxicillin clavulanate, right? And you're actually supposed to use a really high dose, 2 grams twice daily, if the area has a lot of penicillin-resistant strep pneumonia, okay? And so a lot of areas that are in an urban area will qualify for that. They also get the higher dose if they're over 65, if they've been hospitalized within 5 days, if they've used antibiotics in the past few days, if they're kind of multiple comorbid chronically ill people, or if they're immunocompromised. You can also use doxycycline, levofloxacin, or moxifloxacin. Remember that the fluoroquinolones are really moving out of fashion. So if you can avoid them, it's probably better because of this risk of cardiovascular disease and all the chronic risk of tendinitis and things like that. All right, hearing loss. So here we're trying to decide if it's conductive or sensory neural, and we're going to do that with the Weber and the Rinn test, which there's actually a really good picture in y'all's textbook about that. So where the W is up on the head, y'all, and then the R's are the ears. To help you remember that the Weber is in the middle and the Rinn is on the outside. So remember with the Weber test, you do use the tuning fork, you put it on the patient's forehead, and you find out whether it localizes to the good ear or the bad ear. If it goes to the good ear, then that means the bad ear has sensory neural hearing loss, right? Because it's not conducting through the bone into the patient's brain. And if it goes to the bad ear, then it means it's conductive hearing loss, as we could all tell by clogging our ear for a minute, and you would notice that your voice is louder in that ear. So once you know whether it's conductive or sensory neural, that helps you so much with your differential, right? So conductive is going to be all of these things that are outside, all the way from the outside of the ear, going back through the ossicles until you get to the cochlea. Sensory neural is going to be presbyacusis, which is chronic loss of high tones of hearing. So this is why none of my elderly patients can hear my voice unless I talk like this, right? Because of presbyacusis. Drugs, meningitis, Meniere's disease can really cause this hearing loss and is important in a patient, especially if they have some of the other symptoms like tinnitus and vertigo. It can be an acoustic neuroma or something else that's environmental in there. Remember that if you have sudden sensory neural hearing loss, that's a big deal, and you have to go to the ENT doctor and start prednisone because it could be some sort of viral infection in there that we want to recover. That's why you really have to do that test, because obviously if I rupture my eardrum, I can have sudden conductive hearing loss, and it's not necessarily that big of a deal. Okay, Time for some more questions. A 63-year-old woman with diabetes presents with right ear pain and right facial nerve palsy. She has a fever for the past 24 hours and the draining ear shown. Which is the most appropriate treatment? Good. So piperacillin tazobactam and ciprofloxacin IV. There's a couple hints in here that this is a really sick patient. First of all, she has diabetes, and then she has right facial nerve palsy. So remember that the 7th facial nerve goes right through the ear canal and then comes out. This is why people with Ramsay-Hunt syndrome get the vesicles inside their ear and can have hearing loss and also have a facial nerve paralysis, right, when they get zoster of that nerve. And so this is malignant otitis externa, which can be very, very serious and can progress to mastoiditis, which is osteomyelitis of basically the brainstem. And so that's why this patient's going to get piperacillin tazobactam and ciprofloxacin IV. It looks like ciprofloxacin otic would be totally appropriate for otitis externa if it was uncomplicated. The oral amoxicillin would probably be okay, but the problem is that you don't really have the anaerobic coverage without also adding the clavulanate. Okay, a 33-year-old woman presents with sore throat, rhinorrhea, maxillary sinus pressure, and green nasal discharge that's been there for 3 days. Her temperature is 99.2, her heart rate is 90, her blood pressure is 110/70. On exam, she has swollen nasal turbinates, no adenopathy, and a clear chest. What would you recommend? Perfect. Decongestants, nasal irrigation. So she doesn't have these criteria. She doesn't have second sickening. She doesn't have high fever. She doesn't have unilateral facial pain, right? So we're not going to give this lady an antibiotic. If we were going to give her an antibiotic, then we would give her amoxicillin clavulanate, right? So D is our second best choice if she met criteria for any reason. A 67-year-old woman comes in with 1 hour of unilateral right eye pain. The pain started while watching a movie at the theater. Past medical history is notable for hypertension, osteoporosis, and migraines. She takes alendronate and hydrochlorothiazide. Her left eye is normal. Her right eye has mild conjunctival injection. Her cornea is slightly hazy. The pupil is 6 millimeters and poorly reactive to light. She reports halos around the light during exam. In addition to calling ophthalmology, what treatment would you recommend? Good. So she has acute angle closure glaucoma, and she needs these timolol eye drops. Sumatriptan is a very good option if we thought that she had migraines, which some of the halos and other things could go for, but it wouldn't really explain the non-reactive pupil. And then this answer acyclovir, they're trying to suggest herpes simplex keratitis, which can be a really important thing to see, but also shouldn't have any pupillary changes. All right, guys, genetics. So there's different types of inheritance, and we're just going to go through autosomal recessive, dominant, and X-linked. So autosomal recessive, remember, is carried by both of the mother and the father. Male-female incidence is equal, and the recurrence risk for the next child is 1 out of 4. So every child is exactly 1 out of 4. So this is cystic fibrosis, sickle cell disease, a lot of the common things that we hear about. Autosomal dominant disease, on the other hand, is always active, although there can be incomplete penetrance. So one of the adults might not have it to the same extent that the child does, but there should be someone in every generation that's affected by an autosomal dominant disease. The risk to each child of an affected individual is 50%, because you're either going to get my good chromosome or my bad chromosome, and every single child that gets the one that's affected is going to be affected. You can see male-to-male transmission of autosomal dominant disease, which you would never see in X-linked. And you also wouldn't see an autosomal recessive, right? Because the father should not be symptomatic if he's carrying that recessive allele. And then the normal parents don't transmit the trait. So this is Huntington's disease, factor V Leiden deficiency, that sort of thing. X-linked inheritance. So this is where the male is much more likely to show symptoms compared to the female because it goes with the X, and the males have an X and a Y, and the women have an X and an X. So the woman is more likely to have a healthy X to counteract anything else, and so she's more likely to be a carrier, and he's going to be affected. So if if my husband is affected, then every single one of our daughters will have gotten his X chromosome, which means that they'll all be affected, or all be carriers. And every one of our sons will have gotten his Y chromosome, and so none of them will be affected, and none of them will be carriers. If I'm a carrier, then it's equal odds whether my kids are going to get my good X or my affected X. So if 50% of my sons will be affected, and 50% of my daughters will be carriers. So this is hemophilia. There's several different X-linked characteristics. Okay. Pregnancy. So I already mentioned how we take care of 50% of pregnancies because a lot of them are unplanned. And so we'll just start with a question. A 29-year-old G1P0 female with type 1 diabetes presents at 22 weeks of gestation with increasing pedal edema. Her blood pressure is 170/110. UA reveals 3+ proteinuria. She has no headaches or neurologic symptoms. What treatment would you recommend? Perfect, labetalol. So first of all, because we love labetalol in pregnant ladies, right? Beta blockers are outstanding for these women along with calcium channel blockers, but also because diuretics, ACE inhibitors, and nitroprusside are actually contraindicated in pregnancy. So knowing what's contraindicated in pregnancy is half the battle here. So infertility is the first thing to talk about. Remember that we don't need to evaluate it until the couple has been trying to get pregnant for a year. If the woman is over 35, then you move it up to 6 months. You need to evaluate both the man and the woman, and this involves everything. So the semen analysis in the man, we're going to look at the chromosome analysis of both people, and then we're going to confirm ovulation and ovarian reserve in the woman. If all of that's still normal, we can do a hysterosalpingogram to make sure that the fallopian tubes are patent. And then both partners need to stop smoking, stop alcohol, and normalize their weight. Weight loss can be very, very important to combating infertility. On the opposite end, contraception. So we really want all patients on long-acting reversible contraception. We don't believe that pills or condoms are reliable enough. So in general, we try to get all of our patients either an IUD with copper or progesterone or a subcutaneous implant. So these are the ones that release progesterone that goes underneath the skin and last about 3 years. If we can't do any of those three, then we move on to just whatever the patient prefers, whether it's pills or the medroxyprogesterone injection or the vaginal ring, because if she likes it, she's more likely to be adherent. Remember, condoms alone have an 18% failure rate. Although they're important for STIs, they really shouldn't be used as your primary contraception. If someone has a sexual encounter and needs emergency contraception, there's 2 options that they can get in the pharmacy. So either the oral levonorgestrel or the oral ulipristal. Both of them need to be taken within 5 days, and the sooner that they're taken, the better. The other thing that can happen is a patient can get a copper IUD, which prevents implantation. As long as it goes in quickly, within 5 days, then it'll prevent pregnancy. Preconception care. So this is what I was talking about before. So anyone of childbearing age, anytime we're starting a medicine on them, we need to be thinking about the fact that they could be getting pregnant on it. For that reason, all patients need to be on folic acid, especially need to be thoughtful of which patients need 4 grams of folate a day. These are the high-risk women. So if they have a personal or a family history of spinal cord deficit defects, if they are epileptic patients who are on anti-seizure medicines, those are the patients that need 4 grams. For immunizations, we've already talked about that. We talk about environmental toxins and domestic violence. Remember, pregnancy is a very dangerous time in a woman's life from a domestic violence perspective. And then review all meds and pre-existing conditions. So that's what we're going to do next. So we'll start with lupus. So remember, they have normal fertility, but they're high risk for miscarriage. There are certain antibodies that can tell you if the patient is more likely to flare or more likely to cause neonatal lupus for their baby. Remember that hydroxychloroquine is okay in pregnancy, okay? So steroids or hydroxychloroquine are okay, and we really don't want to rock the boat so that we can avoid flares. But methotrexate, obviously, since it's antifolate, is completely contraindicated. Thyroid disease. So most women, when they become pregnant, become hyperthyroid, and their TSH drops below 1. If they're symptomatic, you can talk about beta blockers, PTU, and methimazole. But most of them are not symptomatic and will go back to normal after pregnancy. Obviously, we're not going to give them radioactive iodine, right? If they are hypothyroid and on chronic levothyroxine, you're going to tell them that as soon as they get pregnant, they should increase their levothyroxine dose by 30 to 50% so that you can mimic this normal physiologic increase of thyroid hormone in the context of pregnancy. So I literally tell every single patient of mine who's on levothyroxine that if she gets a positive pregnancy test, then she needs to be taking 3 extra pills a week, right? So that way and then to come in and get her TSH checked. For diabetes, we want their hemoglobin A1C to be normal before conception and have it stay normal for at least 2 months before stopping birth control and keep it there throughout pregnancy. Unfortunately, we can expect that the diabetic retinopathy will worsen and the insulin requirements change dramatically over the course of pregnancy. So you have an increase at the beginning of the first trimester, and then it goes down for a little bit from the first through the second, and then goes back up during weeks 28 to 32. So the patients really need to be very, very careful about monitoring their glucose and keeping their insulin properly titrated. For epilepsy, so, first of all, we already talked about folic acid. The thing to remember is that even though all of the anti-epileptics can cause problems with birth defects, the risk of seizures in pregnancy is actually much more dangerous to a baby. So you're going to try to get them on just one anti-epileptic. It can be almost anything, but try to avoid valproic acid. Okay, that's the one that has the worst problems as far as facial defects and other things. All of the other ones are pretty manageable. Hypercoagulability. So remember that pregnancy makes them even more hypercoagulable. We're not going to do CT scans, and we're not going to do warfarin unless they have a mechanical valve. Okay, so low molecular weight heparin for all of our hypercoagulable women. For hypertension, we're going to treat it. They don't have to have full preeclampsia in order for us to try to bring down their blood pressure. And this is the list of meds. So we already mentioned calcium channel blockers and beta blockers. You also have methyl dopa, hydralazine. The main thing is you just don't want ACEs, ARBs, or diuretics. And then this just reminds you of the diagnosis of preeclampsia. So remember, it's proteinuria, edema, hypertension, and headache. And then they develop seizures if it's untreated, which is why we move quickly on that. The protein creatinine ratio is over 0.3, so it's quite low. And then it can progress until they get transaminitis and thrombocytopenia. This is when we start getting into the realm of HELLP syndrome, which is obviously a very severe complication of pregnancy, and usually the baby needs to be delivered immediately. So just to remind you of the drugs to avoid during pregnancy. So isotretinoin, the vitamin A, can cause major problems for the fetus. I think we've mentioned all of these already. Okay, so bacteriuria, we talked about with elderly patients that they can have bacteriuria in the context of a Foley catheter, and if they're asymptomatic, we don't care. For pregnant women, it's totally different because they're more at risk for developing pyelonephritis, and it also puts them at risk for low preterm birth. So we treat asymptomatic bacteriuria. In fact, we screen for it in pregnant women, although, it's a little unclear what to do if they don't clear it with our antibiotics. Fluconazole, remember, is very dangerous in pregnancy. It can cause facial, bones, heart defects, and even low-dose fluconazole can cause pregnancy loss, so we avoid it all during pregnancy. Okay, a little bit on abnormal uterine bleeding. I think it's important to remember that there's both structural causes and non-structural causes, and the way to remember these is with the acronym POM, COIN. So POM goes through all the structural things from polyp through malignancy, whereas COIN talks about the things that I think we as internists think about more commonly: coagulopathy, hormonal things causing ovulatory dysfunction, that sort of thing. And you want to sort of think broadly about that when a woman comes in with uterine bleeding. And that might be that she's bleeding too much during her periods, or that she's having intermenstrual bleeding, so having spotting in between the periods or having cycles that are either less than 21 days or more than 35. The way to treat heavy uterine bleeding is with high dose, either estrogen, OCPs, or progesterone to get the bleeding to stop. Hot flashes can be very, very bothersome to patients. Remember, even though low-dose estrogen and progesterone can cause venous thromboembolism, cardiovascular risk, and are contraindicated in breast cancer, it's okay to use them for 2 to 3 years to try to help alleviate symptoms and then slowly taper off. If you're not going to use those hormonal medicines, you still have many choices to try to help alleviate these patients' symptoms. One thing that's interesting about paroxetine is that it actually, so it's a psych med, right? So we said that it's an inhibitor of the CYPs. And so it prevents tamoxifen from being converted from a prodrug into an active drug, and actually can make it almost completely ineffective. So it's important not to combine those two medicines. Just briefly about breast health, remember that there's a lot of things that can go wrong with the breasts that aren't necessarily breast cancer. So mastitis, especially in pregnant women, but you have to make sure that you're not missing inflammatory breast cancer. All right, guys, a few more questions. 25-year-old woman, G1P0, presents at 10 weeks of gestation for evaluation. She's asymptomatic. Her hemoglobin's 12, hematocrit's 36, and her urine culture is 100,000 colonies of E. coli. What are you going to do? Perfect. Amoxicillin, right? So we said that the beta-lactams are very well tolerated in pregnancy. Ciprofloxacin and trimethoprim sulfamethoxazole are going to be avoided, and we're going to treat her because of the risk of pyelonephritis and early pregnancy loss. A 27-year-old pregnant woman, late first trimester, presents with dyspnea and pleuritic chest pain. She reports that she has had progressive left leg swelling over the past week. Her ABG is 7.48, 22, and 80. The most appropriate initial diagnostic test would be perfect. Duplex ultrasonography. So her pretest probability of having a pulmonary embolus is so astronomical. If you show that she's got a lower extremity DVT, then you're going to treat her, right, based on that. And so there's no reason to go through the risk and exposure of all of these other things. So I just want to review a few key points about imaging. So a 46-year-old man developed a severe headache this morning while working at his car dealership. He also has nausea and has had one episode of emesis. He has shoulder and neck stiffness that developed today. He denies any history of migraine headaches or any similar headaches. Which diagnostic test should be ordered? Perfect, a CT head without contrast. So here we're worried about intracranial hemorrhage. We need to rule it out quickly, and there's no reason to give him contrast. So the CT scan will rapidly answer our question about intracerebral hemorrhage. If it's negative, what would the next answer be? Lumbar puncture to look for xanthochromia, right? And then if it was positive, then what would we do? We do angiography, right? Because we want to see, we think that he's had a sentinel bleed. This certainly isn't the presentation of like a major aneurysm rupture. And so a lot of times with 4-vessel angiography, you'll be able to find something that you can put a loop or a coil in to prevent multiple ruptures, which happen up to like a quarter of the time in these patients. So there's a CT scan with the blood. Bad news. All right, so when do we do a CT instead of an MRI? This is a question that comes up all of the time, both clinically and on exams. So remember that a CT is better to rule out a bleed. Not because it's necessarily better, but because it's faster, and we don't want to put him in an MRI scan for an hour when he could be having an intracranial bleed. It's also really good to look at bony structures in the head, so sinus disease, facial fractures, look for mastoid osteomyelitis that we were talking about earlier. All of that stuff is good with a CT scan. But for an MRI, it's really better for almost anything where you're trying to really assess the brain parenchyma. So this is going to be demyelinating disease, anything in the spine, HIV-related CNS disease, trying to find brain metastases in a cancer patient. In all of these situations, MRI is better. But remember the contraindications. Now, I don't think we would forget about cardiac pacemakers and metallic implants, but you also need to pay a lot of attention to the social history. If it's a patient who's a welder or a mechanic, then you have to ask them about whether they've had an eye injury in the past with metal to make sure that they're safe to go in the MRI. In Houston, we have lots of patients with retained bullets that we have to be careful about before we send them in the MRI machine. Okay, and then bone scans are another test that are sort of confusing, and it's hard to interpret, whether a positive test changes your differential diagnosis. So remember that a bone scan means that there's active healing or changing of the bone. So there'll be increased uptake if there's fractures, if there's osteomyelitis, if there's malignancy, but it'll only be osteoblastic malignancies, not ones that are going to cause basically eating away of the bone. And so things like multiple myeloma that you see here in the second one will actually have a normal bone scan, which makes it very confusing, honestly, because myeloma, the bones look anything but normal. Or an eosinophilic granuloma. And then remember that you'll actually have decreased uptake if there's decreased blood flow to the area in a situation like avascular necrosis. So guys, this is my last slide. We got 2 questions and we're done. A 31-year-old woman presents with numbness in her left arm and some left leg weakness. She had an episode similar to this 9 months ago, which resolved spontaneously. Exam shows subjective difference in light touch and slight motor weakness in the left leg. Which test would you order? Perfect. Head MRI. That's great. I think that the hint here is that she had a similar episode 9 months ago that went away, which is why you know that this is probably multiple sclerosis and that you need a head MRI. The other thing is that she doesn't really have any pain in her head with it, which an intracranial hemorrhage, you would really expect her to have head pain. The nerve conduction studies, I think in order to choose that, you would have to have something similar, but it would probably have to be not repetitive, not 9 months ago, and you would maybe have stocking glove on both sides or just the arm or just the leg, trying to look for a peripheral neuropathy like a carpal tunnel syndrome, a cubital tunnel syndrome, one of those types of things. A 70-year-old male smoker presents with severe back pain and pain in the pelvic girdle. The x-ray shows osteoporosis of the spine. His white count is 6,000, his hematocrit is 26, his calcium is 12.2, and his bone scan is negative. What is the most likely diagnosis? Perfect. Multiple myeloma. So remember that bone scan, don't let it turn you around, right? He's got anemia, he's hypercalcemic, right? It's multiple myeloma. Any of these other things would not necessarily have a normal bone scan. So thank you guys. It's been such a pleasure.